Good afternoon. Welcome to the combined meeting of Assembly Health and Human Services and Senate Health and Human Services. We're very happy to be here this afternoon. Secretary, will you please call roll?
Senator Lang. Here. Senator Stone. Here. Senator Taylor. Present. Senator Titus. Assembly members Dahlia. Here. Edgeworth. Present. Gonzalez. Here. Goulding. Here. Gray. Here. Hafen. Hibbets. Hunt. Here. Jackson. Here. Koenig. Here. Nadeem. Present. Wynn. Orntlicker. Here. Chair Donyate. Here. Chair Brown-May.
I am here. Thank you so much. If you would please mark Senator Titus absent excused and Assemblymember Hafen present when he arrives. Thank you. I appreciate that. Assemblymember Hibbets absent excused also. Thank you for catching that. Thank you. A couple of housekeeping announcements as we call to order today. Please silence your electronic devices. If you wish to testify, sign in at the testimony table and then provide a business card. Please make sure you turn on your microphone when you come forward to testify. Members of the public may provide public testimony. At the end of the meeting, we will take public comment. To do so, call 888-475-4499, and then when prompted, provide the meeting ID, which is 812-0088-2540, and then press pound. I would like to remind everyone that courtesy and respect in all of our interactions, even if we don't agree with opinions that are being shared today. And please note that committee members will be using their laptops or other electronic devices as we start today. Okay. So with that, we have a number of presenters that are here today with us, and we have 6 10-minute presentations that are slated on our agenda. 6 10-minute presentations slated on our agenda, which is very important. We're here because there are a number of things that are happening of great concern as we're in the middle of our legislative session. It's very important that we spend some time considering federal implications or implications to the state budget that are coming from the federal government. Right? We know that as of yesterday, the issues that we were talking about were unknown. That is no longer, while they're still unknown, we know that there's been movement at a federal level. It is our responsibility as legislators in Nevada to be responsible as we plan going forward. I will ask everyone, as we ask questions and hear presentations today, that we remember to be respectful and considerate. This really is information gathering at this point so that we can be strategic and thoughtful as we plan to care for Nevadans in need of health care and community-based services. So with that, I will invite up our first presenters to the testimony table. We have Director Richard Whitley with us and Administrator Stacy Weeks, who will give us a presentation on the current status of health and human services here in Nevada. You may begin as you are ready. Thank you.
Good afternoon, Madam Chair and Chair Donate and members of the committee. For the record, my name is Richard Whitley. I serve as the Director for Health and Human Services. And with me is Stacy Weeks, who serves as the Administrator over Nevada Medicaid. And we're going to start. We have a fairly short presentation, and happy to answer questions on information that we do have. But just to start with, I wanted to start with what we do know. And with slide 1, what we do know about Medicaid is we know that about 800,000 Nevadans are currently covered. We know that 40% of that 800,000 are youth, and 11%, or about 86,000 people, are duly enrolled in both Medicaid and Medicare, and 66% adults enrolled in Medicaid are employed, underemployed, making them financially eligible. And finally, what we do know is the biennial spending for Nevada Medicaid both state and the federal share is about 5 billion. So not to somewhat to temper your expectations, these are the things we know, and we're going to go through as asked to present some potential impacts that could happen at a federal level. And with that, Stacy's going to go through the financing of Nevada Medicaid.
Stacy Weeks for the record, Administrator of Nevada Medicaid. I'm going to go through a couple slides here. As the director mentioned, we are here today to talk about some of the proposals that have been discussed or ideas that are floating around the federal government. But before we dived in, we thought it would be helpful just to kind of recap on how we finance Medicaid. Medicaid has historically been a federal and state partnership, with the federal government sharing a percentage of the cost of the program. So whatever the costs are as an entitlement program, the state picks up a certain share and the federal government picks up the rest. Under the current federal law, which is Title 19 of the Social Security Act, federal government must pay at least 50% of all these costs at a minimum for each state. The traditional match is based on what we call FMAP, a Federal Medical Assistance Percentage. It's a complex formula, but essentially it relies on state economic conditions. So for example, when a state's economic conditions are poor or going down, the federal share goes up. When the conditions are better and improving, the federal share goes down, but it never goes below 50%. It's based on the per capita income of a state. Right now, when we look at Medicaid today, our traditional FMAP or match is 60, so for every dollar, so 60 cents is the federal share for every dollar, and we pay 40 cents. That's on average what ours is today. For what we call the expansion population, which Nevada did expand Medicaid early on after the ACA, the federal government pays 90 cents on a dollar, and we pay 10 for that population. So as Director Ridley mentioned, currently our program annually is about a $5 billion program, but as you can see, altogether, this last biennium is actually $15.8 billion. I think it's important to note that, as you can see, 60% here is federal funding. And the state picks up about $2.5 billion annually or over the biennium for this population. And the other bucket here is county share. It's also tax payment programs that help fund supplemental payments and other revenue that we can collect and match to help support the program. The other thing just I wanted to note on this slide is that when we think about where all does this money go, often here, I got the question the other day, is Medicaid too big? 3% of this funding goes to our administrative cost and vendors and contracts. The rest is provider payments. So this is not money in someone's pocket. It is going to provider reimbursement. So I just want to be clear on what we're talking about when we talk about this budget. So let's dive into a couple of the ideas that we've heard about at the federal level. When we look at the biggest one, I think we've heard quite about more often than all the others, is what we've heard it referred to as FMAP equalization for the expansion population. And what this means is that instead of having that 90 cents on the dollar, it's moving it back down to that traditional FMAP. So taking that away for the adult population, which is about 300,000 Nevadans that are covered. As a reminder, we cover 800,000, so it's almost half our program are these adult populations where we get 90% federally funded. So when you move that down to the traditional FMAP, our early estimates show for the next biennium that it's a reduction in total federal funds to Nevada Medicaid of $1.858 billion. Now, when you take that pie of federal losses and you want to understand the impact to the state general fund, it is $988.9 million of that bucket. And that is the direct impact of the state general fund. If you can't fill that hole or we don't find ways to make cuts to address it, it would impact coverage and our ability to pay for medical services for that 300,000 people. The other $869 million that's part of that bigger $1.9 billion is loss in federal funds that flow through our supplemental payment programs that we often attach to county transfers of funding to help supplement payments for hospitals. It's also part of our $1 billion hospital tax payment program. So we're of that money, it's about, let me double check and make sure I say the right number here. It's about $336 million in federal funding that would be lost for the hospital tax payment program. The last item here was on the list that came from the committee chairs. I just want to make sure that we're clear. The removal of the 50% for Nevada at this time, and probably for some time in the future, does not have an impact on Nevada because our per capita income is in a position where we don't see it going up as high as some other states that would be immediately impacted by this. But so I just wanted to point out there's no impact for that proposal. So potential federal funding model changes. So the second item that you may have heard about that has been discussed, and sometimes they say it's on the table, sometimes they say it's not, so it's hard to know. But if we really want to look at a per capita model, I think it's important to understand what it is and how it works. So it's really fundamentally very different than how we function today with the federal government and how we pay for this program. It's simply a lot like a block grant, but a little bit different. A per capita cap is really the federal government is placing a cap on funding based on the enrollee and spend over time. So anything that goes over that cap, the state bears the full risk for that cost. This program remains an entitlement program. In the previous proposals, and long years ago, those changes were never made. So if it remains an entitlement program, the state's on the hook to continue paying for those services if they go over the cost. There are two important pieces to a per capita cap. So if one of those does come forward, it's important to look for two things. What is the initial allotment amount? The initial allotment amount is what the federal government will base our federal spending amount on for the rest of, however long the per capita is in place. When we look at a base year for spending, 2024, state fiscal year 2024 is probably our best year in Medicaid, in terms of if you count the provider tax payment program and how much money we received, that would be probably, if I was going to pick a base year, that would be my base year, right? 2023 was a lot less because we didn't have a full state, provider tax program. And also, if they don't include the provider tax program as part of your base, that's also a problem for us. But really understanding what is that allotment year. If it's before COVID, that's a lot less money for the state because our program is a lot smaller. If you may recall, Medicaid was under 500,000 people at that time. So it's really important, what is that initial allotment base? The second item that's really important if this type of proposal comes forward is what we call a preset growth index or your inflation factor. So the federal government will give us a chunk of money and then they'll say, and you'll see, I try to draw this so I hope it looks good, but if you look at this chart here, you'll see the allotment year kind of stays the same, that bottom line. Then there's the growth index. So maybe Medicare economic index, it could be consumer price index and medical, but whatever it is, that's the inflation. They will grow those funds over time. Anything that goes above that inflation, we would have to pay for. So that blue right there is what we would end up paying for as a state. Now, obviously, that's not really based on any real numbers. I'm just trying to visually give you a sense of how this thing works. But that's how these proposals work, and it really just shifts the remaining cost over to the state. I did want to give you a sense real quick about looking at a couple of the inflation factors and give you a sense of how our spend is now in Nevada Medicaid. For example, when we look at the higher probably price or the inflation factor out there nationally, which is the Medicare Economic Index, that's a trend inflation rate of 3.5%. It's similar to what we use in our budget, Moody's trend factor. But when we look at our costs for our program, just to give you a sense of how much we're over the 3.5%, children in Medicaid, our trend right now is 6%. Seniors, 9%. Waiver populations, which is our disability population, 18%. So if we were held at for example, if they pick MEI or something like that, we would have to come down. So that's how this type of per capita cap works. So those are the important factors if a proposal comes forward to really look at. What is that trend rate? Do they let us play with that and do our own adjustment to that? Or is it set, right? And what is that allotment year? All right, we ran a couple numbers just to give you a sense. Like I said, 2024, if we could pick a year, that would be the year of all the years we've had. We'd also pick the national index that's out there that, that's the highest that we could find right now and has been talked to before in the past is MEI. When we look at that, if we were to apply that to the next biennium, again, these are initial estimates, about $590.2 million would be sort of what we would have to adjust in spending. And we'd have to keep our population spend below or pay the remainder if we go over. If you look at sort of the worst case scenario, it would be sort of that 2023 year or even COVID, before COVID. And looking at the consumer price index is a lot lower inflation factor, and obviously that's a much higher number there at $3 billion. If this is combined with a 90% FMAP, these are a lot bigger as well. We are doing some modeling around that, but we did not bring that with us today. The other item that we've heard some be discussed that we wanted to talk through that does have an impact on our healthcare system pretty quickly would be our provider tax payment programs. So just to give you a sense of how these programs work, if you're maybe not familiar with them, we collect a tax on the providers. We use that provider tax revenue, and that we use that to basically pay the state's share of the cost to do a supplemental payment program. Currently, our private hospital tax program supports 43 private hospitals in the statewide. This next biennium, the program is worth over $1 billion. Net to the hospital net gain is about $800 million after they pay their taxes. The proposal, to move forward, one of the things that we've heard is if they move the tax limit, which right now is 6%, which we are at, we are taxing the highest so we can maximize those supplemental payments. If they lower that, which we've heard it could be lowered to 4 or 3%, 4% would be about $693 million in lower supplemental payments for hospitals under this program. The other thing that's important to note that is impacted by our private hospital tax payment program is the work that we're doing on children's behavioral health for the Department of Justice settlement agreement. We rely on a percentage, up to 15% of that revenue goes to support children's behavioral health. And we've been doing a lot of work in this space. I think some of you, we've presented it to you already. If this was to happen, just a reduction down to the 4%, so we couldn't tax beyond that, we would be reduced by about $30 million in state revenues to support those services. And like I mentioned, any of these proposals, when they're coupled with that 90% FMAP loss, everything is a lot bigger. So that 90% FMAP is a really big, piece to the puzzle. And it would increase sort of those costs to over $1 billion for the hospitals. Our skilled nursing facility program has had a longstanding tax program. We also use that revenue to supplement their payments and help try to improve the rates that they receive for Medicaid. It serves about 57 skilled nursing facilities, and we've done some early estimates, and we think that if we were to have to reduce the tax down, we would be reducing payments to these facilities by $95.5 million over the biennium. And again, when it's coupled with the 90% FMAP, it does go up to $130.2 million. Medicaid work requirements, there have been some discussions about these as well. I think we've heard about these many years. Some states have moved forward with programs like these in the past. So it's really hard to know what this will look like. We looked at Arkansas and Georgia and kind of how they implemented their program and applied some of their experience to what we might see here. But typically these proposals require recipients to demonstrate a certain number of hours to show that they're working to be eligible for Medicaid. The initial estimates that we're looking at could be anywhere from 70,000 people could be impacted to up to 112,000 low-income working adults who possibly don't have enough hours to qualify or have other issues with maintaining employment. And it could, looking at sort of the spend reduction for this would be about $441 million or up to $705.6 million over the biennium. I think the important thing to look for in any program like this is state flexibility to design it to meet the economic needs of the state. Some states, like for farmers, we have seasonal jobs and other people that move state to state, and ensuring that we can design, if we are required to design a program, that we can design a program that meets the needs of our members. It's also important to note that some members have not been, our homeless population is often not diagnosed yet with mental illness, substance use, and may, be impacted with not being able to sustain a job. And, obviously there could be exemptions for mental illness, but if they haven't quite been diagnosed and are not covered to get access to a provider to get that diagnosis, these can sometimes be a barrier to care in that way. So I think it's important to understand the impact on those individuals. Let me see, next. So one of the questions that you guys brought forward was looking at state options if there are federal reductions. It's really important to remember that federal law does limit what a state can do to their Medicaid program. There is a bare minimum mandatory set of populations that have to be covered, services that have to be covered, and our provider rates. There's what we call the access rule. There are some requirements and regulation, and yes, they could be repealed, but there is a statute, so they'd have to change statute to remove some of those barriers. But really, reducing rates to a certain extent, we can be told you can't. And they could actually deny our state plan amendment to change our program if it's too low and it impacts access. So we have to really go through an analysis with CMS to really lower our rates now. So some of these are some of the things that we'd have to think about if these things were to come forward. There are only a few areas in healthcare that you can really cut. And same with Medicaid. There are benefits that can be cut and reductions, but only to optional services, not your mandatory services. Now remember, Medicaid was passed back in the day to Social Security in 1965. So back then, what we thought was health care and mandatory is very different than what we think about health care today. So we'll look at that in a minute. So when you see this list, don't be surprised, because I'm always like, why is that mandatory and why isn't this other one? Eligibility reduction is also something we'd have to look at. But again, there are some populations that are mandatory. There are only so much you can cut. Provider reimbursement, I talked about that. We'd have to look at how much can we cut before we get denied by CMS. And then also the other option is to generate new revenue. I know that's not always a fun topic, but it is a part of the conversation. It's on the table. It's something to talk about and think about if we faced these types of cuts. This is just a high-level overview of those mandatory benefits. I always like to point out that, institutional care back in the day was thought of as the care, and nowadays we've moved more and more to that, Olmstead, Americans with Disabilities Act perspective that people should be in their community living. And so those optional benefits that you might think should be mandatory or like home and based community services are actually optional and not mandatory, while nursing facility services, for example, are mandatory. These are just a high-level, quick snapshot of all the populations that are mandatory versus optional. As you can see, and I think in the last presentation I gave to the Assembly Policy Committee, we looked at sort of what our limits are already, or where we're at in Nevada. But there would be some room to move down if we needed to on some of these populations. And then that is all we have today, and we stand for questions. Thank you.
Thank you for your presentation. I really appreciate the detail. I do know that we have a number of questions, but before we start with that, I'm curious to know if we can just clarify a number. The first slide, slide number 2, the line number 2 says $5 billion in biennial spending, state and federal share. I'm curious to know, is that a typo? Just because as we look at slide 4, it says total is $15 billion. Is it just a typo?
Madam Chair, Stacey Weeks for the record. Yes, it should say 15, so yes, thank you.
Okay, good, thank you. We just wanted to clarify
No,
so that we're not confused with how many billions of dollars.
Yeah,
With
it's
the
a
B.
lot. Thanks.
Right, that's a lot of billions. Okay, we're going to start with questions then. I believe our first question is from Assemblymember Ohrenlichter.
Thank you, Chair, and thank you for your presentation. Also on that same slide, too, you have the number of dual eligibles, and that almost 86,000. That just want to confirm that. And also, if you could tell us if there's more about who those people are.
Madam Chair, Stacey Weeks for the record. Yes, that is currently what we consider our dual eligible. So if you're eligible for Medicare and you're low income, you can get Medicaid. Often in seniors, usually our senior population where Medicare kind of fails to cover the services they need to remain at home. And so they have to sometimes spend down and get on Medicaid so they can access these services. I think that's something that is usually this population.
Thank you. And you may go direct when you have a member with a question. Thank you for that. Next question we have from Assemblymember Nguyen.
Thank you, Chair. Thank you for being here. It's great to see you both. Just want to see if you go on slide 7, if the statutory floor of 50% for the federal share were to remove, what would the new FMAP be under the statutory formula?
Chair, committee member Stacy Weeks for the record. Are you referring to the FMAP slide or the per capita cap? I apologize, slide 7?
The FMAP.
Oh, okay. FMAP slide. So it would be our traditional. So if you go to slide 2 or 3, sorry, and you see those, it would be the 60-40 roughly, and the next biennium it's actually 59% federal share. So we go to 90% federally funded to 59% by the end of next biennium.
So there is no fiscal impact to the state.
Chair, committee member Stacy Weeks for the record. Let me go to this. I think this is the slide that you might be talking about. Is this the one, slide 5, that says no impact? No. So there are two. So the 90 to 59%, which is the first one, there is an impact. It's over $1 billion to almost $2 billion. The removal of the minimum is just saying that the federal government can now, for the first time ever, go below 50% in share. Right now, the federal government, so if a state's, like, I don't want to pick on a state, but let's pick on my old state, Minnesota, their per capita income is pretty good. And I think they're close to 50. So this probably would hurt them, right? So it would go down below 50 for the first time ever because their economy is so good. And that formula would show maybe the federal government paying them less. Right now, Nevada's per capita income is high enough, and we don't anticipate that in this next biennium that we would go below 50% in federal share. Does that help answer your question better? Okay, thank you.
Yeah, thank you. Thank you, Chair.
Thank you. Next question we have from Senator Lang.
Hello. So my question is on slide 7. If the per capita caps were set based on historical expenditures, how would this impact Nevada? And also, given the historically low per capita Medicaid spending compared to that of other states?
Stacy Weeks for the record. Well, when we talk about compared to other states, I think it really depends on, it does, I mean, honestly, if they allow us to add in the state-directed payments since last year, we'll be on par with a lot more other states. But you're right, it is based on historically what your federal spend is. So some states that receive a lot more federal money obviously would have a higher per capita cap. But you don't forget that they also probably cover more people. They have a larger program that kind of matches that spend. And I'm trying to, and I apologize, what was your first question again? I apologize.
There's a mic here. It's about, let me see. If the per capita caps are based on historical expenditures, how would the impact be on Nevada, given its historically low per capita Medicaid spending compared to that of other states?
Chair, committee member Stacy Weeks for the record. I think that was the answer I gave earlier kind of solves that question. Yes, we will get less, but again, it matches sort of what our enrollment and our program has been, right? So states that have spent less, yes, will get less, and states that have spent more will get more in that way. But the inflation factor will be very important for most states and how they can handle a per capita cap.
Senator Danyate.
Thank you so much, and thank you, Director Whitley and Ms. Weeks, for presenting. It's always a pleasure to have you in front of us. You know, I want to make sure that obviously we're in a very critical time, specifically discussing this, right? Because ultimately, the conversations that we're going to have as legislators, we need to make a plan in terms of whatever congressional decisions are made. That ultimately can make the decisions as to what we have to cut in terms of programs, right? For ultimately that a lot of Nevadans depend on. And on your letter, you mentioned that there were potentially, in terms of the response, that there are going to be, we could potentially lose some level of Nevadans that will lose access to care. And so the number that we've seen enumerated is 300,000 Nevadans, right, or the 1.9 billion number, which we'll talk about later today. But I want to spend some time perhaps talking about the provider fee, the assessment fee, that obviously we've worked really hard to stand up. You know, last session we worked together to at least capture a percentage of that fee to go towards behavioral health, children's behavioral health, as a response to the lack of adequacy that we've done in terms of providing access to care. And so it's my understanding that the federal government right now, congressional Republicans, are looking at capping or limiting the return that we receive for these types of programs. And so from my understanding, right, if we have a reduction in terms of what we provide for what we receive back for the provider fee, there are no alternative ways of getting that revenue. And so all the initiatives that we've made so far, if there are no ways to pull that funding, then we're gonna have to make cuts. Is that a correct assessment?
Chair, committee member Stacy Weeks for record. I think, just to back up just a second, so when you talk about they reduce the amount of money that we can receive, that technically does not impact our children's behavioral health. So kind of, let's walk it back for a second. If they change the tax rate, that impacts our ability to collect that money that we use. And if they change the tax rate and reduce the tax rate, yes, we would have to adjust those programs, I think, to account for any reductions in spend, unless we can make up the funding in other areas, right? So I think those are decisions that would be left to this body and the governor if that was to happen.
But just to reiterate, there is no current proposal in terms of how we can supplement, essentially, if those funds were to be rolled back and if there was a cap, say, at 3%. Is that correct?
Chair, committee member Stacy Weeks for the record. Yes, currently what's before you is based on current law.
For the record, Richard Whitley, I would just add that the opportunity to maximize that tax has been available in statute, and really it was just taken, other than skilled nursing facilities, which has been maximized at the 6%. It's why they come every session as a group to seek rate increases and need additional general fund, because they essentially are living in the cap. Hospitals came on board thanks to some changes in leadership there, like really brought people together. But that we just started really with different provider types looking at that. But that's just one strategy for getting the state match. And so if the federal government does limit that, not that we take comfort in being less impacted than other states, but other states have really leaned into this much more as just a strategy for the provider tax. But I think we would have to come up with other strategies and present to you. It's hard because we're moving through a process with our budgets based on what is now, and have this potential a change of some kind with a reduction sort of happening at a federal level. And so it does make it challenging for us working forward. We definitely have commenced with trying to maximize the tax opportunities and trying to get provider associations to see the value in it. But other states have lived in the space of creatively funding the state match for Medicaid in a lot of different ways. And so the impact would be there, but we'd have to look at services and also then the funding and maximize what we have. I guess because we are hearing from people, I just want to say that not only providers, we have a fragile healthcare system that we do have to work through this all the time with when changes occur at a federal level, and it doesn't benefit us to have people be fearful when we don't have a known. So we've done some iterations of what ifs, but we haven't played out every scenario, and we don't know yet what those scenarios are. So I just feel like it's important for us to get that. Maybe I should have said that up front, that, we're responding with the questions we're asked to the degree we know. We have to do the regular management of what we have now, anticipate something that might be happening federally, and we have a fragile healthcare system. We did before the pandemic, workforce shortages made worse during the pandemic, and so all these things at one time make it challenging, and I should have opened with that, just the environment we're in, and lots of questions being posed to us, but it's just hard to play out scenarios with it still being unknown at a federal level.
Thank you, Director Whitley. I appreciate those comments, and I know that we all do here on both sides, the Senate and the Assembly. We do have a fragile healthcare system, and I think that's why we've taken this so seriously, right? We have 120 days every biennium to create our plan to be able to support the constituents, our residents across our great state, right? And we really want to be thoughtful in how we do that, knowing that collaboratively we can come together to partner to craft solutions, and we want to work together in that way so that we are caring for some of our most vulnerable. Healthcare is needed for and by every member of our community, and so I appreciate that you're working out scenarios strategically. I think that we want to be a partner in that so that we can help to craft a thoughtful budget before we adjourn at sine die, and that's something that we can hopefully rely on over the course of the biennium. And so I appreciate that we are here together, and certainly don't want this to feel like a gotcha moment, right? Like collaboratively, we're glad that you're at the table and that you're responding to these questions. I think it helps our members better understand what our healthcare system is, because we all work our day jobs, right? And so I think understanding what Medicaid is on a state level is really fundamental, and it's such a complex funding mechanism. As you could see just in the first 3 slides, right, we went from, is it $5 billion or $15 billion, right? Knowing that it's just a typo, but that $15 billion is so significant to every one of the folks that we serve. So I want you to know that we appreciate you and your responses to all the questions, even though they're unknown at this point, and that it is a tool for us to use. With that, we're going to go to the next question, if you don't mind, which is Assemblymember Gonzalez.
Thank you so much, and thank you so much for being here. As you've stated, it's been challenging these last couple of years, and so I appreciate your time and being here. My question is, what would be the estimated financial shortfall for Medicaid, for the Medicaid budget, if the provider tax revenues were reduced?
Chair, committee members, Stacey Weeks for the record. I think it depends on the reduction, but technically they are not a state general fund item. They are funded by the tax, which is an optional program. So if the program is to change significantly, we would work with our Attorney General's office, but I think that we would go back to the hospitals and see if they still want to maintain the tax, because they chose, under state law, it's a voluntary optional tax if the majority voted on it. So I think we would probably just see that program go away if they didn't want to continue it. So, but it's not state general fund, so it doesn't have an initial budget impact where the state would have to fill the hole. It'd be sort of like, can we still maintain taxing these hospitals if we can't pay them the supplemental payment?
Thank you. Next, we have Assemblymember Gray.
Thank you, Madam Chair. Director Whitley, Ms. Weeks, thank you guys for being here and putting yourselves on the hot seat today. Can't be easy. You pointed out the obvious. There's a lot of unknowns right now. A lot of unknowns. So it's I'm really grateful you guys are sitting here. I've fought alongside you guys to bolster our system. We have a very fragile system in this state. But the resolution was just passed by the House last night. Still got to be signed off on by the Senate. This reconciliation process is going to be a long one. There's going to be a lot of give and take. So we don't know what's going to happen. That being said, can we go back to the slide to the optional and the mandatory services? So if you were put in a position where you had to start making cuts, where would you start on that? And if you don't want to answer and you're not ready, fine. What I'm getting at is I'm wondering if we can come together and develop a plan that is best case scenario, worst case scenario, and then somewhere in the middle. And probably using that as the guide, and then with whatever information we get from the feds once this whole process is done.
For the record, Richard Whitley, we're not prepared to take a pick list. I mean, we've been through this before when the economy has had a downturn at the state and have had to reduce. I see Mike Wilden is in the room. He has had to do this as my predecessor when and they're not easy decisions, but they are done collaboratively with the legislature. We bring forward within those optional services. Yeah, I think we can't just look at the services. We have to look at the utilization and the impact. And as Stacy Weeks mentioned, a lot of these rules are truly outdated in terms of when the legislation was passed for Medicaid. And so, I mean, I can't think of anyone who would say that pharmaceuticals aren't a part of basic health care, but it's optional. So we can't pick from that just given the services, but would have a logic on what we would bring before the body as we have before on any reductions that we might propose to make to balance our budget.
Thank you for that. I appreciate it, sir.
Thank you. Next, we have Senator Taylor.
Thank you, Madam Chair, and if you'll indulge me, I'll have 2 questions, if that's okay. Thank you so much. And like everyone else, we really appreciate you being here, so thank you. It's late, it's a difficult time, and all of that. So again, just thank you both. If we can go to slide, let's see, I wrote it down right here. If we can go to slide 8. This is sort of a follow-up to my colleague's question, Assemblywoman Gonzalez. Would Nevada, would we as a state, right, would we need to reduce provider rates, provider reimbursement rates for certain provider types like hospitals or something like that in order if we get into a situation where we don't have enough money? And if so, how much?
Chair, committee member Stacy Weeks for the record. The provider tax payment program would not affect, if that is the problem, right? If we're looking at that issue, any changes to that are really truly would not impact the rate we pay. These are the supplemental payments that we pay on top of the rate to try to improve how much they get. So I'm sure that they would come to us and ask us to try to put more state money in so they don't have a loss on that side. If it's some of the other proposals where you're losing federal funds, like I said, there are lots of different options we'd have to look at. But like Richard said, these are not easy decisions. We'd have to look at utilization. We'd have to look at how much if we cut, how does it impact access and outcomes and things like that. So, I don't think I don't think any state would probably take all of their losses out on one area, right? But like I said, you have provider rates, benefits, and eligibility. And that's the balance.
Thank you, Madam Chair. My second question is, you mentioned how seniors are sometimes, in particular seniors, find themselves in a situation where they have to spend down so they can qualify. Will you tell us, what does that look like?
Chair, committee member Stacy Weeks for the record. Typically, I don't want to speak on behalf of the eligibility team, but there is a process where they have to spend down their income and value assets so they qualify for Medicaid and some of those home and community-based services and other things. We also have a state recovery. So for individuals who maybe have more money and we can recover some of the cost of providing them care. But the Medicare program, while it is the program seniors usually have, right, when people retire, it does not cover the full suite of services that really people need. And so often that's why Medicaid really becomes sort of a need for these families.
Thank you so much again, Chair. Thank you for your indulgence.
Thanks. Next question we have from Assemblymember Dahlia.
Thank you, Chair, and thank you both for being here and spending your evening with us. I have a question in connection with slide number 8. So how would changes to provider tax revenue impact Medicaid waiver programs, such as those that fund home and community-based services? Thank you.
Chair, committee member Stacy Weeks for the record. It would not impact our waiver programs. Those are funded very differently. These are the supplemental payments to hospitals. Thanks.
Thank you. Next, I believe we have Assemblymember Hunt.
Thank you, Chair, and thank you guys so much for your presentation. My question is, what would Medicaid cuts do to our mental and behavioral health care system in Nevada? because this is a concern of mine, because we're last or near last in the nation for mental health care.
For the record, Richard Whitley, I'll start. And as you know, we do have a fragile behavioral health system. We made some great strides last session with the provider, the hospital, voluntary hospital tax that Stacy mentioned, and we're really just getting those services stood up, faced with the same challenges other states are with workforce. But certainly, if it impacts people being eligible or service rates, any one of those strategies of reduction would make an already vulnerable system perhaps more vulnerable. The workforce challenge is our big one. Our hope was that we could really tackle that going forward. And I think that even though the goal is to keep people living as independently as possible, we still have a need for institutional facility-based care as well. Those are very much dependent on rates that we pay. And so we're trying to attract providers in our state and keep them here. And again, a fragile system. And so looking at changes of any kind, even looking at additions, you see in our budget things that we've tried to be thoughtful about where that investment would help. The same would be true with undoing anything or reducing anything. It would need to be strategic, and we would, often providers of service come at us with wanting to stand something up, but we always look at what the need is and look at the earlier intervention. Perhaps a cut on something could lead to a more costly expense down the road if it was preventable, or if intervening could make it better. It often is less costly. So I can't say in particularly what area, but we would look at if these reductions came down and they impacted behavioral health, acknowledging that it's already a fragile system, that we would need to be precise and need to do it in forums like this, where we've engaged the public and the consumer and took that all into consideration and looked at the data on what the use is. So any reduction would be impactful, just like any investment would hopefully be impactful for the benefit.
Thank you.
Thank you. If you don't mind, while we're on slide 8, I'm just curious. So this shows that we're serving 57, we have programs in 57 skilled nursing facilities. How many Medicaid enrollees are in those skilled nursing facilities? Do you know?
For the record, Richard Whitley, we can get that for you. You do know that Medicare made changes for long-term stays, and so Medicaid has become the largest payer for long-term stays, and that gets at what Stacy was saying earlier, but we could get the number for you of actually how many are in there. And we, related to the behavioral health question, we also, Medicaid stood up a enhanced rate for behaviorally complex folks who really keep them out of higher levels of institution when long-term care is what they need.
Thank you for that. I think our next question is from Assemblymember Goulding.
Thank you, Chair. Thank you both. I'm on, referring to slide 9, and I'm wondering if you could expand a little bit on folks that aren't working, that are on Medicaid, and if you could paint a picture for us of what does this population look like? Are we talking about retirees, people with disabilities? Give us an idea of who is most likely to be impacted here.
Sure. For the record, Richard Whitley. And I would say that we've looked at this before with the Supplemental Nutrition Assistance Program. They some rules were lessened, but work requirements, it's a little higher poverty levels, but there is certainly an overlap between the two populations, and in that program they're considered able-bodied, not disabled. And it would be the same with Medicaid. It would be people who don't have physical reasons that would be a barrier to their working. We could provide the data. We have looked at that. I didn't bring it with us, but just looking at what that demographic looks like in terms of a breakout, sometimes we show the data and it's like, but is that true for everybody? Or are there some populations that are more highly impacted? But we could get that for you in terms of we're looking at it because we're anticipating some requirements coming down on the SNAP program as well. And so I know that's not the topic of this hearing today, but looking at work requirements for probably a Venn diagram of a population that is not disabled, not aged, not children, but are what in the past the federal government has referred to able-bodied.
Okay, so I'm sorry, just for a point of clarity then. So if we're talking about folks who can be working right now, is there folks that are eligible now? Why are how many working folks and how many non-working folks do you have that could be working?
Sure. For the record, Richard Whitley, some of the individuals are underemployed. We do an annual report on the employers with the largest number of employees on Medicaid. Walmart and Amazon are 1 and 2, that kind of flips. But the state of Nevada is on there. My department employs the largest number of employees on purpose. The welfare division recruits eligibility workers to become employed, to move them through and have work experience, but they may be working but may be underemployed. And so again, the strategies for the population that is capable of working, it isn't just get a job, but it's like, if you're a single mom with 3 kids, we can do the math to know how much you have to make to move out of poverty. So how do we help you progress to earn that amount? And so I actually, we've been looking at it in relation to both SNAP, the food program, and Medicaid. But I'm glad you asked the follow-up because the clarification is that people are working, but their poverty level is such that they're financially eligible. That's that expansion population that Nevada chose to participate in. And those folks are largely not disabled, not elderly, and underemployed. I think it would be worthwhile for me to provide that demographic data to you because I think it would, we report our caseload out in snapshots, which sometimes gives the impression that the same people are in this program forever. And that isn't the case. People come in and come out. And the goal is to get the people who are able to work into livable wage jobs and to move out of poverty. But I'd be happy to follow up and get that data.
Thank you so much for completing that picture and for your thoughtfulness in the program.
Thank you. Next, we have Assemblymember Nadeem.
Thank you, Chair. Thank you for the presentation. My question is, what types of diagnostic and screening and preventive services are considered optional?
Chair, Committee Member Stacy Weeks for the record. Typically, those are not. Those are in the mandatory side. So like for children, all screening, diagnostics, and treatment are all mandatory up to 21. For adults, they're not always, but a lot of those are on the mandatory side. But we can follow up in more detail.
Thank you. Next, we have Senator Danyate.
Thank you so much. More of a follow-up request first, and then I'll make my question after. I know there were exhibits submitted in terms of the racial demographics of folks on Medicaid. Maybe if you could provide that afterwards. And I know that we chatted offline in terms of in the email that I sent more of how many people are enrolled in these optional eligibility programs, right? So that we can quantify and see what's the patient population that are affected by such decisions. So obviously, we'll talk more offline with that. More of a clarification issue on slide 11, talking about the optional benefits. You know, there's obviously a concern that if we are put in a position that ultimately, right, and you kind of hinted at this, that it depends on utilization, it depends on the patient population of who's enrolled, and it depends on the level of cost. But on the optional benefits on slide 11, I saw hospice care. I'm assuming home health care is also one of the optional benefits. I didn't see it listed, but is that something that's mandatory or optional?
Chair, Committee Member Stacy Weeks for the record. There is a federal definition of home health services that's mandatory, but more of the PCA, some of the home care is optional.
Thank you. And then just a really quick clarification outside of what I have requested in terms of data points. Director Whitley, maybe you can help us answer this question. You know, I was not a part of the COVID-19 session for the cuts. I was here in 2021. Historically, obviously, we have a recollection of what were the types of programs that we have historically cut. Can you provide some context as to what we've done before, maybe during the COVID-19 session? That way we understand of what were some of the decisions that ultimately legislators had to. So maybe if you can refresh us on that.
For the record, Richard Whitley. I mean, some of the, you know, I remember one specifically from the past, like supports for elderly people living in their home and adult diapers, things that are needed if you're in need of that, if you have a need for that service, and we're trying to say we want you to live in your home as independently as possible, but wraparound services that are supporting the person to be successful. Stacy Weeks mentioned personal care workers. I mean, a lot of our aging folks rely on somebody helping them with their activities of daily living, which seems pretty essential to them. So again, I say that to just tell you that we don't take any of that lightly as like a budgetary item, but the impacts on people. The other thing that we implemented were some prior authorizations to actually, you know, we didn't want to eliminate a position, but to actually do more review to see if it was actually needed. Which bureaucratically plays for providers as a barrier for utilizing a service sometimes. But we used a variety of strategies. We looked at rates. We have to give notice, and those take sometimes longer to effectuate a change. But we would need to look at each service and then the strategies, everything from prior authorization to the elimination or the change in what service is provided if it's optional, and then put that together in total, looking at that population we're trying to support. So it's much more than a line item budget strategy that we have to put forward. And so I'm not going to do it justice in 10 minutes. It needs the strategy of all the elements we look at in the context of the people who are in need of that service.
Thank you. Next question, we have Assemblymember Ornlichter.
Thank you, Chair. I'm looking at slide 11, also on the mandatory versus optional services. And as you warned us, some of these are surprises, including having prescription drugs as an optional service. And one of our options, as you said, will be to reduce optional services. So I'm curious about the implications for prescription drugs of if we have to reduce that optional service, especially for life-saving drugs. What are we talking about?
Chair, Committee Member Stacy Weeks for the record. I just don't think we can answer that kind of question today. I mean, it depends on the level of cuts, right? And I think when you think of the benefit set, there are other ways to probably make cuts where you don't take out an entire service. So I think we'd have to look to see what prescription drugs are the high cost, maybe what's not life and death, but those are those are kind of the conversations we can't really go to until we have more information about what we need to do.
If I may, for the record, Richard Whitley, if I could just add, though, it makes even more important, I think, our recommendation to look at a Nevada Health Authority with purchasing power and the ability. Pharmacy probably is the best example of that, that we've seen in other states that have actually joined together with other benefit programs and have purchased and maximized the dollars they have. It becomes, I think, even more important if the resource is limited. So I just wanted to add that too as a support of looking at something new that we're presenting, but it really is the cost strategy that perhaps when the session started or when we built our budgets, we looked at cost savings, but it may be sustainability of services that this would benefit. But I do think that the strategies, sometimes innovation does come out of looking at this sort of thing. It certainly has helped us look at the population that overlaps with several programs where poverty is the determining eligibility, and if those categorical programs are working with some synergy, there is an improved outcome. Sometimes the invitation to do that doesn't happen until there's a crisis. Certainly out of COVID experience, telehealth and other benefits, Meals on Wheels as a social service network to check in with the elderly became even more important to us and recognized. They've been doing that work forever, but the need for them becomes realized in a crisis. So I just would say that the opportunity there to look at how we purchase becomes even more important.
Thank you. Next, we have Senator Stone.
Thank you, Madam Chair, and thank you very much for the presentation. The Trump administration and going through the DOGE program has already recovered $66 billion in fraud and waste. And I think that Medicaid is fair game, Medicare is fair game, Social Security is fair game. I personally believe there's a significant fraud in some of these federal entitlement programs. In fact, the Natural Health Care Anti-Fraud Association estimates that in Medicaid alone, there's $50 to $100 billion in fraud. So I applaud the president in examining these organizations without the knee-jerk reaction that we're going to be taking away these programs from needy citizens in this country that need these services. What do you feel has been the impact of fraud on Medicaid in Nevada? And have you seen the proactiveness of the federal government like you're seeing today in trying to eliminate fraud and abuse in our Medicaid system?
Chair, committee member Stacy Weeks, for the record, fraud in Medicaid program, especially provider fraud, is prevalent. It is a lot of work on our team. There is money there, but that process is a very long one. Often when the FBI becomes involved, these are criminal cases, it takes us a long time to move. So I think the faster that process can be for Medicaid programs so we can actually collect and disenroll and take action, the better. So I do agree that there is room to do more on provider fraud. I think it is real, and it's real for Medicaid in Nevada.
Thank you.
Thank you. Next, we have Minority Leader Hafen.
Thank you, Chair. And I first, if I may, I just want to thank the Chair for having this evening. I think we're all a little confused with what's going on out there at the federal government right now, so I think this is a great opportunity for us to get some better answers on, what could possibly happen. And so, having said that, I want to thank you, Director Whitley, and Director Weeks for all of your hard work. Nevada has always run a very lean budget, especially when it comes to DHHS. You guys have always been prepared and diligent. I know now we have the largest rainy day fund that we've ever had. The question asked by the senator about COVID, I was here when we made those cuts. It was not easy, it was not fun, but it was necessary. And so I just wanted to go on the record and say thank you for what you guys have done, what you've prepared this evening. A lot of work has gone into trying to figure out what might happen. Hopefully it's nothing. What I'm hearing is that hopefully it will be nothing, but I do want to thank you for being here tonight, trying to ease some of the confusion and frustrations that a number of us have. So thank you again, and thank you, Madam Chair, again for hosting this evening.
Thank you. I think we're almost there. Assemblymember Gonzalez.
Thank you so much. I want to turn to slide 12, and I just have two questions. I'm wondering if you can identify the income threshold for a family of 4 that's at that 185% FPL, and then also for pregnant women that are making 133% and 185% of the FPL, please. Thank you.
For the record, Richard Whitley, neither one of us have that, but we do on some of our websites where it is helpful to translate. What does that mean, you know? And then there's actually a nice grid that actually shows like a family of 2, a family of 3, we don't have that with us, but it is worthwhile to look at, and certainly that is the consumer experience.
Thank you for that. If you don't mind, it would be great if you would be able to get that and share that with the committee. I think it would just help us understand a little bit more who that consumer is. I do have one question, and it's really curiosity. We talked about the hospital provider payments. We're almost done, right? We're just about done with questions, so thank you for your time and attention this evening. We certainly appreciate your willingness to come and talk with us. And your cooperation. We're going to hear from the Hospital Association. We're going to hear from lots of other associations that are directly serving in the healthcare space. And I'm just curious to know, can you speak a little bit about the current provider payments, the provider tax that's supporting our healthcare system? Is it working? Are there delays? I know that we had some codes that were shut off. Are we operational? Can you just give us a quick update with regard to how that's working?
Chair, committee member Stacy Weeks for the record. Yes, we are in state fiscal year 2 of the program. Last state fiscal year went really well. All the hospitals paid. We didn't have any issues with delinquencies. That's really a great thing. I will say right now we are still waiting for calendar year 2025, our preprint to be approved at the federal level. Until then, we are not paying out the federal payments on for the program for the state-directed payments. So that has been kind of a waiting. We're waiting on that piece for the program. So you may have heard some of that from hospitals.
Thank you. And just a quick follow-up then, is it affecting the patient care at this point? Because that's really where I'm less about the dollars and cents and more about the quality of patient care. How is it affecting our patients?
Chair, committee member Stacy Weeks for the record. I apologize. I'm in budget mode, but I think the Hospital Association probably can best answer that question for you about the impact on the hospitals in quarter 4 of the state fiscal year.
Thank you for that. Thank you. Senator Danyate.
Thank you so much. And I just as a wrap up in terms of my closing remarks and just as a response to the presentation, I just want to first and foremost thank you for collaborating in terms of giving us as thoughtful of a response that you could. Obviously, it's a very difficult process of being able to financially project different scenarios, and I think we tried getting as much as we could to answer that. And ultimately, right, we're receiving different numbers from reports, right, from the Kaiser Foundation. That's why we uploaded that as exhibits so we can reference it. I know there's going to be follow-ups to it, and just really quickly before moving on to the, more of the closing, but it's interesting that we bring up Medicaid fraud or other types of fraud and abuse in the system, because ultimately what we see are actually that they come from the providers themselves taking advantage of billing on Medicaid. And so I think that's something that obviously the Senate Health and Human Services Committee will take on, and I look forward to working with my colleagues and of course with you to help address that. And then more so on this subject, right? We talked about the importance, and we're about to hear from our providers in terms of what these cuts mean when people are kicked off from the plans, right? If we no longer allow for certain eligibility of folks, right, then that means that the individuals that have relied on this, right, the seniors, the children with disabilities, families impacted by the most for this safety net service will no longer be able to access healthcare because of the coverage gap, right? And ultimately, that shifts the burden now to the rest of the taxpayers. That's why it's an issue for all of us to be impactful for this. But Director Whitley, maybe outside of this committee meeting, I think I've mentioned it to you before. Today, we spent a long time talking about Medicaid, but there's other factors of the healthcare system that will be impacted. For instance, public health, right? There are a lot of federal grants that might be at the chopping block in some way, shape, or form. And so there's also the consideration of the Affordable Care Act subsidies not being continued, right? And whether or not the plans that we have on the healthcare marketplace, if they're accessible to folks, if we're in a position of kicking them off of Medicaid. And so I look forward to working with you and hearing from you, perhaps in different presentations. And I mean, and ultimately, right, for all of our colleagues here, this is an issue that impacts all of us, right? We took an oath to protect the safety and the health and wellness of our citizens, of the people we represent. And so I just thank you for answering our questions and for being a part of this process.
Thank you. I would like to echo the comments of my colleague and appreciate having the opportunity to be here and to have you be willing to come to the table to talk with us. We know that it was just over a decade ago that we, our wonderful Governor Brian Sandoval invested in expansion of the Medicaid population, and Medicaid is only one part of our overall healthcare system, right? We're really talking about the integrity of healthcare and our constituents, so I appreciate that, and how we can work together across the aisle in a bipartisan fashion to really care for our citizens, I think is why we're invested in this conversation today, so that we can be thoughtful as we progress through the rest of our legislative session. I know that you can't give us concrete answers, and we respect and appreciate that you are willing to be collaborative, and truthfully, ingenuity sometimes comes out of crisis, right? So I thank you for your comments there. You talked about our fragile healthcare system, right? That impacts all of us, and so we look forward to continuing to work with you to figure out how we can shore up all of healthcare for all of our constituents. I hope that you will stay with us and listen to the rest of the presentations, just so that you are as well informed as we are as we continue to go forward. You're welcome to offer closing comments if you'd like.
Now, for the record, Richard Whitley, of course, will stay. The people presenting are our partners too, and we in all these forums we also learn and certainly engage, and so that is what makes our healthcare, I think, a system. Is a lot of the solutions are we're a small enough state that people can get on the phone if there's a regulatory barrier or if they have a great idea to do something that solves a problem. And so we will, of course, stay and be happy to answer any questions that might come up at the end.
Thank you. Okay, we will close that presentation from the Department of Health and Human Services. Next on our agenda is the Nevada Healthcare Association. Mr. Brett Salmon is here to join us. And you may begin, sir, whenever you are ready.
Chairs Brown May and Senator Doñate, members of the committee, I'm Brett Salmon with the Nevada Healthcare Association, BRETT, and yes, it's salmon like the fish, so it's a wonderful name. So I appreciate the opportunity of being here today and wanted to, before I start my presentation, thank the 2023 legislature for your help with Nevada's nursing facility reimbursement rates during the last session, and we wanted to publicly thank you. I've thanked many of you individually, but wanted to thank you, those of you who are there in 2023, for your help with Nevada nursing facilities Medicaid rates, and we'll talk a little bit about that today. I also wanted to thank Director Whitley and Stacy Weeks. We spend a lot of time working with them, particularly on implementing our Medicaid rate increase. And so during this presentation, if you see Stacy's eye twitch, I may be a little off on my numbers, but I'm doing my best. But I just want to give a little bit of a background on nursing facilities in Nevada, and then talk a little bit about our reimbursement system. and then a little bit about the potential federal issues that are out there that we potentially could be dealing with. And so there's about 60 nursing facilities in Nevada with about 6,500 beds and about 7,800 employees. And amongst those employees, I just kind of broke out our nursing staff. About 40% of those are CNAs, 19% of those are LPNs, and 17% of those are registered nurses. A little bit about the Medicaid that we provide in nursing facilities. Obviously, it's an incredibly vital program for us, very important to the care that we provide. 60% of all the care that we provide in nursing facilities in Nevada is to Medicaid residents. And I think that there was a question previously about the number of bed days. I think Chair Brown, May, that was you. It's 1 million to 1.2 million Medicaid bed days per year in nursing facilities and long-term care. And to the right there, on the bullets to the right, I just kind of wanted to break out sort of if you took the entire nursing facility Medicaid funding package, 60% of our budget is paid by the federal government, 15% paid by the state, 14% paid by providers through the provider tax, and then 8% is paid through the counties. Some of our payment sources, we obviously have fee-for-service payment sources, managed care payment sources, and then our supplemental payment, which is the provider tax. In our fee-for-service category, we obviously have our per diem rate. We have, for those facilities that have vent units, they have standalone ventilator rates. We have several pediatric nursing facilities in Nevada, and they receive a pediatric rate. And then there's a behavioral rate add-on in the behaviorally complex care program, where nursing facilities that participate in taking care of those with behaviors, there's a rate add-on in nursing facilities. I would say that a large majority or almost all of our nursing facilities participate in that program throughout the state. On the managed care side, for those facilities that participate in Medicaid managed care, the managed care organizations are responsible to pay for the nursing care for the first 180 days. And then at the 181st day, then those nursing facility residents would revert back to fee-for-service. And Director Whitley and Stacy Weeks already kind of spoke to this, but I'll just give a little bit of a background. The nursing facilities in Nevada adopted the provider tax in 2003. I didn't, way before my time here, but I didn't realize we were so cutting edge, but we've been doing it for 22 years. And we maxed the provider tax program right away because we needed the revenues during that time, and we still need those revenues. And so we are maxed under the program, and obviously if there were cuts, that would be a significant impact to nursing facilities throughout the state. A little bit after the program was first approved, we added a Medicaid threshold to incentivize providers to take Medicaid in the nursing facilities. So the way that it works in our system, if you have 65% or more Medicaid in your facility during the reporting period, then you pay the lower tax amount. If you have less than 65% Medicaid during that reporting period, then you pay the higher tax amount, and those are the tax amounts currently. And so what that means to the nursing facilities is the providers pay about $48 million in tax, and then $80 million is returned in federal match. And that program has been incredibly vital to sustain our program the many years that we've had it, and we're very supportive of the program. In nursing facilities, Stacy talked a lot about FMAP rates. We have a standard FMAP rate of 60%, like she spoke to, and the ACA expansion population, which is the childless adults under 65, is a 90% match. And currently, before CMS, kind of back to our 2023 Medicaid rate increase, we're still working with CMS to get the final portions of that approved, and there's a preprint approval pending for calendar year 2024 and 2025. And if approved, then those payments will be paid directly through the managed care organizations. So to the issue at hand in dealing with the potential federal cuts that are out there, we have a national association that is very directly involved in negotiations, very involved with leadership on both sides of the aisle. I spoke with them this week, and to almost every question that I asked them, the answer was, I don't know. And I think that's pretty standard for most people right now, that we're kind of in a lot of limbo. They put out a press release today, my national association, saying, please don't cut Medicaid and please don't cut nursing facility programs. So they're obviously concerned, and we're obviously concerned here in Nevada as well for that. And so we'll obviously be watching it very closely. I will refer you to Stacy's presentation on the financial impacts of all the various scenarios and how that could impact our programs. At the risk of kind of beating an analogy to death, the squeezing the balloon analogy that we all use, I think it's important to kind of think about this as you deal with this as a legislature, and then as our federal partners deal with these issues with Medicaid. You might squeeze the balloon to solve one problem, but then you might inflate many other problems as a result of that. And, you know, Pat Kelly and I with the Hospital Association talk about this, where we're very interconnected. We're in a healthcare continuum together. Often there are things that happen to hospitals that then impact us very directly, and vice versa. Sometimes things happen to us reimbursement-wise, and it hurts hospitals. And so we're very sensitive to people being cognizant of the fact that we are in a collective continuum. We're all connected to each other. Nursing facilities don't stand alone. We're very connected, you know, with the home care that's provided, then the assisted living care that's provided, then to a nursing facility, and then to a hospital. We're all connected with each other, and so if there are cuts in one area, often that impacts other areas, and that's what I'm hoping that we can be cognizant of as we consider whatever happens at the federal level. And regardless of any federal outcome, we want to pledge our partnership with the legislature and with the governor's office and with our congressional delegation, just to make sure that any issues that we as an association will be helpful to provide solutions to potential issues to protect the seniors that we love to care for. Thank you, and I'm happy to answer any questions. And I'll just remind you that the less questions you ask, the quicker you can eat.
Members, do we have any questions? Senator Danyate.
Thank you so much. I have plenty of questions to keep us late.
Having trouble.
On a more serious note, I want to talk about, obviously, you kind of hinted at it, but I want to just verify, obviously, what happens in the healthcare system, right? You mentioned that we're all interconnected in terms of the level of care that we often respond to. Obviously, if there's a cut in Medicaid patients that are no longer eligible for providing or receiving a level of coverage, right? That's going to result in two systems. Number one, either we might have to deny folks because we might not be able to take them on if they're uninsured or self-pay, which means that there is no place to take them on. Or number two, as healthcare administrators, we would have to go back to the drawing board and ask our commercial payers, we would have to revise their contracts to ask for a higher rate to supplement the Medicaid cuts that we received. We already operate on slim margins as it is, but there's going to be a shift that is going to occur towards the commercial payers, to the other taxpayers that are not reliant to the Medicaid system if a Medicaid cut is done federally. Is that true? Is that a fair assessment?
Chair Donyate, absolutely true, because it already happens in our system, and it would just happen more. Currently, because Medicaid is the lower payer between Medicare and Medicaid, the cost shift happens to the private payers already, and that cost shift would just be accentuated by any sort of cuts that happen that way. When you said about the margins on managed care contracts, those are already pre-negotiated, and they would have to be renegotiated. That's a difficult process as well, but in the meantime, there would just be a cost shift that would happen to the private payers.
Thank you, and Chair, if I might just follow up. So ultimately, right, the positions that we're going to fall into for these healthcare administrators is either we close down facilities or we start to turn people away, correct?
Brett Salmon, for the record, yes. Chair Donyate, already, we've kind of experienced that during COVID where nursing facilities had to limit their admissions because of staff and because of their ability to cohort, COVID. And what happened is the nursing facility residents that should have been taken care of in the appropriate setting were in hospitals, and then it backed up hospitals. And that's exactly what would happen in this setting. It would be a shift to the hospitals, and the hospitals would bear the burden and at a higher cost for them too. So.
Thank you. And then just one last question, more dealing with the cost shifting that exists to other taxpayers to subsidize, of course, the folks, like, we're going to pay for this regardless in some way. So this idea of we're going to save tax dollars by kicking folks off is not true, right? We have to take care of folks at some point. Do you happen to know what the level of uncompensated care is for skilled nursing facilities? Is that something that you've talked to your members of? I know that's more of an issue with hospitals, providers, but do you have that?
Brett Salmon, for the record, there may be cases of that where we have Medicaid penders where maybe they can't find the documentation and ultimately they give up on it and they have to eat that. But I would probably defer to Stacy's team on answering the uncompensated care side for nursing facilities.
Thank you. Members, any other questions? No, I do have one. Sorry, for just one moment. You don't get away yet. My question is about the flow of care. You have short-term beds and long-term beds. So you have long-term residential care, you have short-term rehabilitative care. We have all different types of payer sources, right? So this is not a funding question. I don't want to go there. I want to go to a strategy and planning question. As you came through COVID, we know that some parts of our healthcare system were stressed and overstressed, and people did not have a place to go. So tell me, what does that look like in this care setting, right? When a pivot happens and patients, there's no space for them in a hospital setting, how do we get them from a hospital setting into a long-term care setting? And really my question is, do you know how many patients are expected to come into your facilities? And do you have the capacity, are we able to plan to do that if there's a downturn in federal funding that supports your organizations?
Brett Salmon, for the record, I guess the way I see it, it would go the other direction. So I think that if nursing facilities were stressed financially and there had to be significant cuts, then that would impact the amount of workforce that they had, so they wouldn't be able to provide the level of care, or they would have to shut down wings in their facilities, and as a result, those residents would have to go to hospitals because they wouldn't be able to. Some could be taken care of in their homes, but most would have to go to hospitals, and as a result, it would just put that stress up to the next level.
Thank you for that clarification. I appreciate that. Okay, seeing no other questions, thank you so much for being here today. We appreciate your time.
Thank you very much.
Okay, we'll close that presentation from the Nevada Healthcare Association. And next on our agenda is the Nevada Hospital Association. Please welcome Mr. Pat Kelly and friends. Please feel free to introduce yourself, and you may begin when you're ready.
Thank you, Madam Chair. My name's Patrick Kelly, the CEO of the Nevada Hospital Association, and with me is Jeannie Giroux. She is going to be helping me. I've been experiencing tremors in my hands and having difficulty with fine motor skills, so she's going to help me a little bit tonight. But don't worry, I still can talk, so we're in
Thank you,
good
Mr.
shape.
Kelly. All are welcome, and we appreciate the assistance.
Thank you. So we're going to start off with some basics. There are 65 hospitals in the state of Nevada. We have acute care, critical access, behavioral health, long-term acute care, rehab, and federal. People always ask me, what are the three federal? We have a VA in the northern part of the state, a VA in the southern part of the state, and the hospital at Nellis Air Force Base is included in that. Hospitals provide $6 billion in economic impact to the local communities. We employ over 35,000 people. And in 2023, we invested over $667 million in capital improvements. And the reason I share this is to kind of put this in a little bit of perspective. If hospitals start to experience significant Medicaid cuts, all those numbers will be impacted in our communities. So if you look at the population now, we have about 20% of our residents are Medicaid beneficiaries. And that 20% is important when I go to the next number, and that is 31% of our inpatients are Medicaid recipients. So it's out of proportion to our general population. We have a lot sicker population in terms of the Medicaid folks. And then if you go to the next slide, we have 31% of acute care, when you look at 31%, you see that we have 31% are Medicaid patients, 44% are Medicare patients, and 3.5% are uninsured. Now, all these groups typically pay less than the cost of the care we provide. So we have 78.5% of our patients who pay less than their actual cost of care. So if there is a cut in Medicaid reimbursement, that really does have an impact upon us. We treat about 1.26 million people in our EDs, and 31% of those, again, are Medicaid patients. So it's disproportionate to their representation in the general population. I want to talk about Medicaid reimbursement for a minute. There are really two buckets in which we're paid. One is base rates, and one are supplemental payment programs, and Administrator Weeks talked about this a little bit. But in terms of the base rates, in the last 22 years, we have only received a 5% increase in rates. So that's not 5% every year for 22 years. That's 5% in 22 years. At the same time period, our hospital costs increased 71%. So it's way out of proportion. And this is why the Medicaid provider fee program is so critically important to the hospitals and why we decided to move forward with it. So I've been asked about what would different cuts amount to. A 5% cut in our base rate would be about $41 million, and it would put us back to rates of 2002. Now, the Medicaid provider fee program is the second bucket, and that's the supplemental payment programs. And it's a program by which we tax ourselves, and that money is then sent to the federal government and is matched. As was pointed out earlier, part of that program, 15% of the money that is used or collected is going to go to administrative expenses to run the program and for enhanced behavioral health services. And I'll tell you, this is pretty exciting because, as we all know, our behavioral health services need a lot of work. So this is finally a pot of money that's available to expand those services. But, you know, if there are cuts to Medicaid, that's something that could be reduced, and we might not be able to do everything we want to do. We currently have in the provider fee program 43 private hospitals. And when we say private, we're basically saying that they're non-governmental. We have nonprofits, for-profits in the program. The government-owned hospitals have their own supplemental payment programs, and they've had those for a while and are operating. But you look at it, and these 43 hospitals are currently projected to pay $387 million and receive a net benefit of $830 million. So it's a big program for us. But I do want to note, and this was brought up by Administrator Weeks, we're not getting the money. So there has been a snafu sort of at the federal level. The preprint to allow us to be paid the state-directed payment portion of the program was filed in the fall of last year. It was not acted upon during the Biden administration. And then when the Trump administration came in, they put a freeze on everything, and this was part of the freeze. So one of the challenges we've had is we've paid about $90 million to have matched, and it can't be matched now. So the state has really made some great efforts to help us by using fee-for-service money to pay some of that, but we're not even close to being equaled out. So it's a challenge right now, especially for some of the smaller facilities. You know, it always comes down to cash flow. The challenge of these programs is you always have to pay the tax months before you get the money. So it can cause potential problems. So I want to go through 3 potential cuts that we hear a lot about at the federal level, and this is just related to the Medicaid provider fee program. So the first one is that they could reduce the amount, the maximum amount that we can be paid from the average commercial rate to Medicare rates. And that would be a substantial difference. I mean, we're probably looking at hundreds of millions of dollars there. But that one is an incredibly difficult one to calculate. The next one is they would reduce the percentage of revenue that is taxed from 6% to 4%. And we calculate that out to be about a $264 million cut every year. And then the third is reducing the expansion population match rate to 59%. And this is just related to the provider fee program, but that would have a $336 million hit for us in the provider fee program. So the other potential cuts that are out there, and Administrator Weeks talked about this, is just the Medicaid expansion group going from 90% to either 59 to 60%, which is our current FMAP rate, or down to 50%, which is the lowest. So that has a lot of issues. The other thing is, if there's a decision made that we're going to cause some people not to be eligible anymore, they're going to become uninsured, and they're still going to come to the hospital. And so basically, we're just not going to get paid when we treat them when they come to the hospital. There was a little talk about Medicare or block grants, the per capita caps. That obviously will have a big impact on us. But one of the questions that was asked earlier was about unreimbursed care at the skilled nursing level. I'd like to talk to you about that at the hospital level. So we're projected this year to expend about $1.382 billion in unreimbursed care. And of course, if there are any future Medicaid cuts, that number is going to go up much higher. And the sources of unreimbursed care are Medicaid paying less than the actual cost of care and patients without health insurance. So I thought this pie chart would be helpful to you. The chart as a whole represents that $1.382 billion of unreimbursed care. So if you look at the green part, that's the provider tax if we got the money, and that's $830 million. But it still leaves $500 million of unreimbursed care the hospitals are experiencing. And a lot of these issues, when these cuts are happening, hospitals are going to be the ones who are going to get people. As we heard from Mr. Salmons, that if we can't put them in the nursing home, they're going to remain in the hospital. And so they're going to be taken care of there. We're going to have so many more people coming into the emergency rooms seeking care because they're not going to have access to care any other way. So, we expect these numbers to unfortunately go up if there are substantial cuts. So when you think about all this, it's really all going to depend on the decisions that the state has to make. They're going to be incredibly difficult decisions. They are not only going to affect Medicaid beneficiaries, hospitals, but all providers. And so, I applaud you for starting to think about this early because it's going to be a huge issue potentially going forward. Now, I was asked to describe some of the potential impact of Medicaid cuts, and I want to emphasize the fact that this is potential impacts. So if we had Medicaid cuts, we would probably reduce access to care for Nevadans. It would create longer wait times to receive services, and it would place a heavier reliance on hospital EDs for access. Medicaid cuts could also reduce or eliminate services. Every healthcare facility is going to have to figure out how they're going to remain financially sustainable, and there are some programs that are extremely expensive. We'd probably be also looking at reducing bed capacity. Medicaid cuts could also increase the number of uninsured Nevadans, make it more difficult to serve a growing population. I mean, this is tough when areas of the state are just exploding and we're not going to have the money to keep our infrastructure and keep building it. And then Medicaid cuts could interrupt some of the efforts that we've undergone in terms of improving behavioral health, graduate medical education, and physician recruitment. We are so low in the number of physicians in the state, 46 out of the country. And we've really made some great gains in the last couple of years in this area, and there's been a lot of focus on it, and I'd hate to see us move backward. And then finally, Medicaid cuts could reduce the economic impact hospitals have on their communities. At the beginning, I talked about $6 billion of economic impact, and of course, that will be affected if Medicaid cuts would occur. So the bottom line is that access to health care services will become more difficult if there are some substantial cuts to Medicaid. So I really thank you for taking a look at this early. Appreciate the opportunity to address you today, and I'd be happy to answer any questions.
Thank you for your presentation. Thank you. Members, do you have any questions? Senator Daniate.
No, really, I'm going to keep us all night. I'm going to keep going. Mr. Kelly, I don't know, and forgive me if I'm asking questions that precede you, but I want to spend more time talking about what the Affordable Care Act expansion did, and obviously the cuts that we had during the pandemic. I think that the context of history is important, especially if we're about to replicate the same behaviors, right? And so, obviously, in 2020, back in August of 2020, there was a consideration of a 6% rate cut that was initiated during a special session. Were you a part of the hospital association by then, or is this a conversation that came up with your members about what happens when we do rate cuts and how we experience that downstream to the providers?
Pat Kelly. So what I have talked to my members about, and one just actually today said, I really hope you emphasize the fact that if you look back 10 years ago, before the Medicaid expansion program took place, we had so many hospitals that were operating at a negative operating margin. And there was a great fear that we were going to lose some hospitals. And when the expansion came in, that took all those people who were uninsured, who were coming to hospitals, and at least provided some payment. As you saw, the rates weren't high, but it's certainly better to get some kind of reimbursement than no reimbursement. So that had a big impact and helped hospitals.
Thank you. You were gonna, if Chairman, you led to my next question, which is, I presume that through the expansion of the Affordable Care Act, right, when folks received coverage, we saw some level of reduction of folks waiting last minute to go to the emergency room. Is that correct? You kind of hinted at that of, if we make cuts, people will delay care, which will expand the uncompensated care rate that we already are experiencing.
Pat Kelly. Senator, that's a great point. I would say that initially when we had the expansion, a lot of people who hadn't gotten care for a long time, all of a sudden we're getting a lot of care. So it was actually a little bit more expensive initially. But to your point, as time has gone on, we're not seeing the crisis situations and really deteriorated health conditions like we had in the past, because they are coming and they have access to health care.
Thank you. Thank you so much. Anyone else? Assemblymember Hafen, Minority Leader Hafen.
Thank you, Madam Chair. Thank you, Mr. Kelly. It's good to see you this evening. Just want to get to the nuts and bolts real quick. Under the worst case scenario, hospitals will continue to provide services, correct?
We are going to do everything, Pat Kelly, we're going to do everything possible to be there for our communities.
Thank you. Anyone else? Members, I just have one question, if I may ask. Can you tell me about the number of uninsured people that accessed hospital care before the expansion, the number of underinsured after? Does anybody have that number? Numbers of uninsured accessing hospital systems?
Pat Kelly, for the record, no, ma'am, but I'd be happy to get it for you.
Thank you. Senator Daniate.
Thank you. Sorry, I just remembered one question. I received an exhibit from UMC about the level of impact that they could receive. Can you speak more to how certain hospital systems, for example, Renown up here in North Nevada, UMC, Sunrise comes to mind, how they would be impacted because they have a higher share of Medicaid patients, and ultimately, right, what could potentially mean is if there's a reduction in Medicaid reimbursement or rate enhancements that we had, that must mean that they have to start closing ancillary services that, you know, they expanded because they had all these funds, and now they won't be able to provide the same services as before. So they might have to close certain wings or certain programs. So maybe if you can touch point on why some hospitals, especially those that are like the safety net hospitals, might be impacted more.
Pat Kelly. Senator, you're absolutely right. I mean, we're going to see all the hospitals are going to be impacted, but those with trauma centers, those in communities where there's a high Medicaid population, they're all going to be seeing more people. And the 3 hospitals that you mentioned in particular will be definitely impacted by this. And whenever that happens, you've got to take a look at all the services you're providing and decide which ones you can maintain going forward. So, I mean, I think I said earlier, the state's going to have to make some difficult decisions. Hospitals are going to have to make some difficult decisions as well.
Thank you so much. We appreciate your time tonight. Thank you for joining us. Thank you for your presentation.
Thank you.
Okay, that closes the presentation for the Nevada Hospital Association. Next, we have the Nevada Primary Care Association. We welcome up CEO Nancy Bowen and Policy Director Steve Messinger. You may begin whenever you are ready.
Thank you, Chair. I am Nancy Bowen, the CEO for the Nevada Primary Care Association. Steve unfortunately couldn't be with us tonight. Just a really quick introduction. We did have our Community Health Provider Day yesterday, but so some of you may have heard this, but real quick, we represent the federally qualified health centers, or they're commonly known as community health centers. They're funded to provide services, primary care services in underserved areas and populations. Really designed to serve Medicaid and uninsured patients. We accept everybody and provide services to everybody regardless of ability to pay. A lot of those are on sliding fee scales for those who are unable to pay and do not have insurance. A very important piece of community health centers is that they are governed by a patient board. 51% or more of their board are patients. And they provide integrated care, which is primary care, behavioral health, dental care, and care coordination. This is just an overview of all of our members. We have 8 Nevada-based federally qualified health centers. Some of the associate members are also organizations, nonprofits that are wanting to become a federally qualified health center. And we do have a few tribal organizations. This is where all our federally qualified health centers are throughout the state. The majority are in the urban areas, but we do have several in the rurals. So if we look at the 2023 numbers, we served approximately 117,000 unique patients, 389,000 visits. There were at 53 locations, and we do have 9 mobile units which go out to the rural areas, and they also do serve the urban areas as well. 88% of our patients are at 200% of the federal poverty level or below. 30% are served in a language other than English, and 30% of those patients are uninsured. So when we talk about Medicaid, it is extremely important to the health centers. It is about 39% of the patients that they serve, and that's about 45,000 patients. So health centers, really the funding for health centers we call it a 3-legged stool or 3 pillars. It's the federal grant that they get, which makes up about 13% of their revenue. And then there's the 340B prescription drug program, which some of you have heard about yesterday. That makes about 15% of the revenue, and then Medicaid makes up a good 25% or $56 million for the state in 2023. As I said, 39% of the health center patients are on Medicaid, and about 27,000 of those 45,000 patients are adults, and that was because of the ACA expansion. So the expansion estimate is 89% covered lives, or 24,000. About 54% of the total Medicaid patients and 21% of total patients overall for the health centers. So when we look at worse, and for revenue purposes, a Medicaid patient brings in about $1,200, $1,300 a year to the health center, as compared to an uninsured patient, which is self-pay, which is about $141. So only 10% of the revenue. And our estimates are that 89% of the Medicaid adults would lose coverage if expansion was eliminated. So that's the worst case scenario for us. When we look at what could happen with the pending Medicaid cuts, it would be, if they cut the adults, we're estimating approximately $121 million the health centers will have in lost revenue between 2025 and 2028, which is truly and utterly devastating to them and not financially sustainable. So elimination of the Medicaid expansion applied to the 2023 numbers is just $56 million in loss for the health centers, or 25% of their health center revenue. Their revenue is sort of, if you look at their revenue, patient revenue makes up about 58% of their revenue, and grants cover about 42%. So this is, when you look at it, it's 53% of the, or 53% of patient non-grant revenue if we were to lose Medicaid coverage for adults. Health centers operate with very high overhead costs. They have expensive labor, which is provider labor typically. It is also the way they make their revenue. If we would expect a reduction in capacity, if we have a reduction in revenue, it's one follows the other. And sadly to say, we would expect to see 29,000 fewer patients than we saw in 2023 if there was a cut to Medicaid. They would move to uninsurance, so uninsured. So as we all know, primary care is essential for keeping Nevadans healthy. Primary care is basically preventive care and chronic management care. Our clinics actually do save money for taxpayer dollars. It's a proven program that it is a saving. It saves the healthcare system. It keeps patients out of the hospitals, as you heard from Patrick Kelly, how devastating it would be if they had to get more patients in their emergency room if they're treating chronic care conditions. Any savings that we have for not insuring our neighbors would be quickly erased because they will go to the emergency room. And primary care for uninsured Nevadans means that we will receive diagnosis with no coverage. So the concern would be cancer patients. Health centers do cancer screenings. Uninsured patients have a hard time finding specialty care. So takeaway, health centers really are, they're making their contingency plans now. I just came from a board retreat with our CEOs, who are the CEOs of the health centers, and we're already discussing contingency plans. What are they going to do if Medicaid is cut? We anticipate maybe additional uninsured patients and a reduction possibly in federal grants. It's, as we've heard before, it is all unknown. We have no idea. We're looking at the different case scenarios. Health centers overhead suggests that there would be revenue loss, as you've heard. It could be up to $120 million over 3 years. When they lose their revenue, they have to look at reducing services. They have to look at reducing staff. They are all, I've heard from CEOs, they really don't want to reduce their staff, so they're trying to find ways to do it. But unfortunately, if they don't have the revenue to pay for the staff, then they don't have then there's nobody to provide the services. Wait lists continue, and then unfortunately visits to the emergency room for things that should be covered in a primary care clinic. Best case scenario, if the state could spend dollars on health centers to keep health centers open and primary care available to residents, it still wouldn't solve the problem of the needed specialty care and the hospital care. And this is quick, because I know we're all late, so any questions?
Thank you for your presentation. Really well done. Under 10 minutes. We do have a question from Assemblymember Nguyen.
Thank you, Chair, and thank you to the CEO for your quick presentation. I know you were in my office just recently, and we were talking about some of the challenges even at the communities like the API community that are often overlooked because everybody thinks that they have the access they need, right? So you were talking about the care coordination, right? You not only have the primary care, the dental, and then behavioral, but also care coordination, right? Are there contingency plan in place in terms of like when cuts happens and everybody's still coming to you because they have nowhere else to go? What happened to that care coordination part? I mean, where are you going to send them?
That is a good answer. We're still in the, Nancy Bowen for the record. That is a good question. We really don't have a, we're just going to do the best that we can. Care coordination is really through community health workers. We're still working out our scenarios, so I really can't answer that question, sorry.
Just a quick follow-up, Chair. So, and I just want to make sure I clarify this too, because I come from this world, so I understand, federal qualified health centers that serve medically underserved population and medically underserved areas. Those are a lot of different terminology we use. So I just want to make sure that, we put on record here that this is only just capturing just the medically underserved population. And that, the minute that the funding goes away, I'm trying to figure out, just putting out there for you to state, in terms of the volume that you see. Like, what are the number of volume that go through all of your health centers on a typical day?
Thank you, this is Nancy Bowen for the record. We sort of look at things not on a typical day, but in a year. We had 117,000 patients, that just uniquely. I think the estimate was, if I go back to the slides, well, we don't have a concern about the federal funding, like the grant, but that's only 13% of our funding, right? It's a program that's loved on both sides of the aisles. We haven't heard anything saying that they're going to reduce the funding for the community health center program funding. The big concern for us really is the Medicaid. So it's 25% of our patients. So I think it was, where is it at? 24,000 is the estimate, 24,000 patients. So I don't know how that would be on a daily basis. What we're really concerned about is there are some also the executive orders which may impact our health centers. And so the uninsured rate may go up. It could also be impacted. The uninsured numbers could also be impacted.
Great. Thank you for clarity. Thank you, Chair.
Thank you. Members, any other questions? Thank you. I appreciate you taking the time to be here with us tonight and to answer many of our questions. I would love to follow up more with the uninsured portion, right? So if there are changes to the federal funding structure that we have, how will it affect the FQHC? And I know you talked to that in detail. I'm just wondering if we could follow up later with what do you feel like the monthly impact is going to be, just to give us a better idea of quickly, if our numbers change, what will that look like?
I could follow up on the monthly impact. Like I said, it's not certainly, we don't look at it monthly, but I will gladly get that information to you. What we have seen as a trend over the last few years is that as Medicaid, as our percentage of patients that are on Medicaid goes down, it seems to go up in the uninsured. When the ACA happened, you saw a big shift from that went on Medicaid and the uninsured rate went down. Slowly each year, it's been rising about 1%. It rose, I think, about 4% when the individual mandate was removed from the ACA.
Thank you for that. That's interesting. I appreciate the detail. Thank you so much for being here.
Thank you.
Okay, that closes our presentation. And next we have the Nevada Rural Hospital Partners, Mr. Blaine Osborne. Thank you. Welcome. It's lovely to see you. At 6:02 p.m. this evening, you may begin whenever you are ready.
Good evening, Chair and members of the committee. My intro said good afternoon, but good evening. My name is Blaine Osborne, and I'm the president of Nevada Rural Hospital Partners. NRHP is a consortium of the 13 critical access hospitals in Nevada. That is every rural hospital with the exception of Elko, who is a little bit larger than a critical access. To be a critical access hospital, you cannot have more than 25 inpatient beds, and you must be located more than 35 miles away from any other hospital. The Critical Access Hospital designation came about in the Balanced Budget Act of 1997 in response to the growing number of rural hospital closures across the country, and it ensures that Medicare reimburses these hospitals for their costs. The only rural hospital we have had closed in Nevada is Tonopah back in 2015. Since then, Tonopah residents have struggled to get access to care. Many have to travel to Hawthorne to get care, and in emergencies, many are taken over to Bishop, California, Reno, or Las Vegas, and have limited transportation options to get home. This is really tough testimony to give, and I struggle to answer a lot of these questions. I have not modeled what a 5%, 10%, or 15% reduction in Medicaid looks like, and it is difficult to say how many Medicaid beneficiaries in any given rural community fall under the expansion population, and what a cut to the FMAP from 90% to 70% or to 60% federal share might look like. So I defer to Medicaid on more specifics for that data. I also don't want to be misconstrued that Blaine got up and said that if this House budget passes, that means rural hospitals are going to close or that long-term cares are going to close, because that is not entirely true either. Nevada is a resilient bunch of people, especially rural Nevada. The sense of obligation that our CEOs have to keeping services alive in their communities is truly inspiring. They will do everything in their power to avoid closing services or the hospitals. Last session was the best session for rural healthcare probably ever, in my opinion. We passed a bill providing cost-based outpatient reimbursement and cost-based swing beds for critical access hospitals. We passed a bill that made the private hospital provider fee program a reality. We passed a bill to give rural hospitals a rural emergency hospital lifeline in the event that they are faced with closures. We passed a bill recognizing the good work that CRNAs do in rural hospitals. We passed a bill providing more guaranteed loan repayments for providers than ever before. And with the support of this body and Governor Lombardo, more good came out of last session than ever before. We also have incredible partners in support of Nevada Medicaid, and some of those bills have only recently gone into effect. The Medicaid cost-based outpatient reimbursement dollars just began to be distributed in November. The swing bed dollars just began being distributed last month. In 2023, 9 out of 13 critical access hospitals had a negative operating margin. And as a result of the bills last session, our CAHs are starting to do better financially. Instead of just surviving, our hospitals have begun expanding and providing more services to their communities. Significant Medicaid cuts would put all of those things at risk. In many ways, as you've heard from others tonight, it is also very early for us to be answering some of these questions. I had the pleasure of visiting our nation's capital just 2 weeks ago and met with Senators Cortez Masto and Rosen and Congressman Amodei, and I believe all three of them understand the very serious nature of the proposed House package and the potential that it could have on Medicaid cuts, and I have a lot of faith in our federal delegation. Without speaking for them, but considering some of the comments we've heard from the Senate and from President Trump, the takeaway I had was that this House budget proposal is not likely to pass as is. So I look at a lot of these questions as kind of what is the worst case scenario that could happen? What if Nevada faced a $2 billion or a $6 billion shortfall to cover for Medicaid, and how would that impact the rural hospitals? On inpatient admissions, the average Medicaid percentage in rural Nevada is 12%. That ranges from almost no Medicaid admissions in Incline Village to a high of 23% in Fallon. For outpatient visits, the average Medicaid percentage in rural Nevada is 14%, ranging from a low of 5% in Incline Village to a high of 23% in Lovelock. In the emergency room, it is much higher, with an average across rural Nevada of 27% Medicaid, ranging again from a low of 9% in Incline Village to a high of 37% in Pahrump. When you add Medicare into those numbers, you will see the payer mix for almost every CAH is more than 50 or 60% in government payers. Looking at the percentages just on a strictly revenue basis, about 26% of Pershing General Hospital's revenue is strictly Medicaid, about 22% in Battle Mountain, 20% in Boulder City, and so on. So, if Medicaid cuts result in hospital closures, which Nevada counties would be at the highest risk of losing healthcare access? The hospitals that I worry about the most are our smallest volume hospitals. They have almost no margins to be able to absorb any substantial cuts to Medicaid. These are Grover C. Dills Medical Center in Caliente, Pershing General Hospital in Lovelock, South Lyon Medical Center in Yerington, Mount Grant General Hospital in Hawthorne, and Boulder City Hospital. With the exception of Boulder City Hospital, those are all county hospitals who are at their caps in what they can collect in ad valorem taxes, and would likely get no additional support from any of those counties. All 5 of them also have distinct part long-term care units. I think that this would probably be the first service that most of them would be forced to cut. Swing beds would also be drastically cut or eliminated. Some hospitals would have to explore cutting their physical therapy services. One critical access hospital has a geropsych unit that is comprised of about 40% Medicaid admissions. That would likely be cut. Rural health clinics may also be cut or closed. And the proactive expansions and services that I mentioned earlier, such as advanced wound care programs, patient transportation services, the building of clinics, hospital renovations, all of that would stop. The 3 critical access hospitals that still have obstetrics and routine delivery services would probably have to cut those services as well. If there were significant Medicaid cuts, every critical access hospital would face serious challenges. The 6 that receive the provider fee, Carson Valley, Incline, Banner Churchill, Boulder City, Mesa View, and Desert View, would all lose significant amounts of money. In fact, half of those hospitals would probably be stuck paying the tax and not getting anything back in return. Again, I believe each of these hospitals would explore every other option, including converting to a rural emergency hospital and closing inpatient beds before ever shutting down the hospital for good. But in the worst case scenario of significant Medicaid cuts, rural Nevada would feel it the hardest. Lastly, I would also make a personal plea to this body to seriously evaluate all the legislation before you this session and consider the impacts that these bills might have on rural hospitals. If we are facing significant Medicaid cuts, the more mandates that we put on hospitals, the harder it will be to keep them open. There will be a straw that breaks the camel's back, so we still need your help. With that, I would stand for any questions. Thank you.
Thank you for that presentation. Thank you. Members, any questions? No. I have a request also, if you don't mind. Yeah. Do you have one? Go ahead, Senator Danyate.
I think we're about to request the same thing. Wonderful presentation. I think you highlighted at the end the importance of if there are any potential ramifications to this conversation, it's the critical access hospitals that are going to feel it first, right? You know, Ms. Stacy Weeks presented a slide of where are the highest density of Medicaid patients, and oftentimes it's where your hospitals are located. And so maybe more of a request, if you can provide a breakdown to us of like, for all the hospitals that you represent in your association, what the threshold is of Medicaid patients, that would be helpful for us. And then I'm more interested, of course, in the volume of some of the services that you mentioned that would be cut, right? PT services, psychiatric services. That to me is very detrimental for 2 reasons. Number one, you're helping me at network adequacy for many of those areas. And so if you don't provide them, then where are the patients going to go? The answer is nowhere. And so maybe we can talk more offline, and that could be more of a follow-up, but that was the only request that I had. Thank you, Chair.
Certainly. Thank you, Senator. Blaine Osborne for the record. We will absolutely work together on providing you that data. Additionally, just right immediately before we walked into this hearing, Medicaid was able to get us some additional data on some figures of FMAP. So we will supply the committee with more data.
Thank you. Members, any other questions? No, Mr. Osborne, I do have one request. If you wouldn't mind leaving your comments with our staff, I think that you had a great presentation, and I'd like to get it in record. You didn't have a presentation, so testing our auditory abilities at 6 p.m. was quite brave of you. Thank you for that.
Thank you, Chair.
Thank you. Thank you so much. That closes this part of our presentation. Next, we will hear from both United Way of Northern Nevada and United Way of Southern Nevada to talk about how the potential funding changes will impact the nonprofit sector. Thank you so much. I see them. They are in Las Vegas. Please come forward. State and spell your name for the record. You may begin. It is now 6:12. We are being pretty close to the 10-minute mark at each one of our presentations. Thank you so much.
Thank you so much, Sam Rudd with United Way of Southern Nevada. I believe you said to spell my name. Is that correct? For the record, Sam, S-A-M, Rudd, R-U-D-D. Good evening, and thank you for the invitation, Chair Brown-May, as well as Chair Donete, and the members of both the Senate and Assembly Committees of the Health and Human Services Committee. Again, as I said, my name is Sam Rudd, and I have the honor of serving as the President and CEO of United Way of Southern Nevada. As mentioned, we are doing this presentation in collaboration with my colleague, Blake Ping, President and CEO of United Way of Northern Nevada and the Sierra. Unfortunately, he had a family conflict that he was not able to attend today. But this has been done in collaboration. With me here in Las Vegas is Janet Quintero, Vice President of External Affairs, and Henry Rosas, External Affairs Manager of United Way of Southern Nevada. And we are honored to present and share with the committee the state of the nonprofit sector and the impact of recent federal actions. The presentation does include Medicare funding, but also other impacts from federal funding changes. United Ways of Nevada role is that we are a community convener and serve as a facilitator to the nonprofit sector and community-based organizations. The information presented today is representative of our statewide coordination and collaboration. I want to start first of all with what we do know. We know that the nonprofit sector plays a pivotal role in delivering social services in Nevada. We also know that nonprofits are experiencing uncertainty in the way they manage their programs due to recent changes, and that the short-term effects of the OMB funding freeze, although rescinded, are significant. What we don't know, and as others have shared, what we don't know is quite a bit, but we do anticipate that we need to determine, as we work through this together, the long-term impact of federal funding changes to the nonprofit sector and the communities they serve. We do not know the severity of the impact to the social services sector and the communities that they serve. We do want to share that this overview is not a statistical analysis, but rather it is self-reported real-time data from the nonprofit organizations that we requested this information from. And I also want to take a moment to thank the nonprofit organizations that have supported us in getting this information. The next slide we'll talk about is the state of the nonprofit sector in Nevada. We all know that 1/3 of the state budget comes from federal funding, and that nonprofits receive a portion of these funds through various means. And they do, in order to, when they receive these funds, they are able to provide vital services in every corner of our state. An overview provided by the National Council of Nonprofits discusses how important nonprofit partnership with government agencies are. And that is because the nonprofits know their sector and the communities they serve. And if the nonprofit sector was not here to provide those services, government would need to increase direct services to fulfill the needs that are being met. Foundations and individual giving cannot fill the gaps if there are cuts in government funding. Nationwide, 31% of the nonprofit sector revenues come from funds earned under government grants and contracts. This has an even greater impact in Nevada due to our small government and heavy reliance on nonprofits to provide these critical services. Also nationwide, only about 13% of revenues come from foundations, individuals, and corporations for nonprofits. This is even less in Nevada, as we are 49th in the US for philanthropic giving. An overview provided by the Nevada Grant Lab nonprofit sector analysis in 2023 shows that nonprofits employ over 46,000 people in Nevada. There are about 625 active operating nonprofits in the state, providing more than $2.4 billion in programs and services for our community. And according to that same study, the sector remains much smaller by workforce and assets compared to similar regions. And this creates unique challenges for our sector and our state. We'd like to talk about the timeline of the nonprofit sector coordination since the OMB memo was presented on January 27th. As we know, the memo released a requirement of suspending distribution of funds while review of the grants and funding was underway. The next day, the United Ways of Nevada hosted a rapid response call in participation with Nevada Grant Lab and met with about 350 nonprofit leaders. We also that same day asked for an initial survey in response to the impact that this potential freeze would have on the sector. And we received responses from 28 organizations across the state. The following day, on the 29th, the OMB memo was rescinded. However, the federal review continues. We've continued to collaborate and work with the nonprofit sector, requesting additional information and finding that there has been a concern about presenting information without being anonymous. So we made changes to those surveys to be able to accommodate and get the proper information. We've collaborated with Legal Aid Center of Southern Nevada, Nevada Grant Lab, and continue to partner together to continue to provide communication, technical support, and legal insight to the nonprofit sector. We also met with the Office of Federal Assistance to collaborate on data gathering to get a greater understanding of the impact of federal funds to state agencies and nonprofit sector staffing and individuals impacted by services. On February 21st, United Ways of Nevada launched a second survey and received 160 entries, each representing a federal funding program. To highlight the short-term impact, I want to just focus on the final bullet on the slide for sake of time. Even small pauses and potential reductions have a devastating impact on nonprofits that are already stretched thin, potentially causing immediate cuts to vital services. Critical business decisions to continue programming while waiting for reimbursement become more and more difficult when committed and contractual funds may not be honored. I want to first of all focus on the survey results from the 160 responses, the second survey. We want to show by the chart here that every county in Nevada was represented by this. Again, it is a slice of information. It is not all of the information. But it is indicative potentially what we would see statewide. From those reported of the 160 responses, $214 million in federal programs are received through direct or pass-through sources. And the impact is approximately over 100,000 Nevadans in regards to services that are received by these organizations. Looking at the constituencies most impacted, I'm just going to highlight the top three: are children, parents, and seniors, and people with disabilities. On the next slide, looking at the source of funding by federal agencies, you can see the various source of funding. 65% of the reported grants of the 160 responses are received through state department or municipalities. And the largest funder is the Department of Health and Human Services, followed by the Departments of Agricultural and Education. It should be noted that 11.7 million of the 214 million reported included in the survey comes from Medicaid, and all of the respondents expressed concern over potential funding cuts. The next slide will talk about administrative impacts to nonprofits. In the days following the release of the OMB memo, 38% of the respondees indicated that their reimbursement portals temporarily shut down and their funding was frozen. In the weeks following the federal review, 6% of grants have received compliance notices or requests to modify their budget to align with the president's executive order or lose funding. 8% of the grantees reported an immediate impact on full-time staff. Some nonprofits have also reported longer reimbursement times or lack of communication from grant managers even after the federal freeze was blocked. Why this is important? Many nonprofits do not have the cash on hand to sustain prolonged periods of delays in reimbursement without missing payroll or reducing services. Even just a few days of delay can create major impacts to people receiving rental, food, or healthcare assistance. What we attempted to do with this data, on the next slide you'll see, is to truncate the various services provided into 4 categories. The first category would be considered housing, which would include rent, mortgage, and transitional housing, and food and utilities. 26% of the 160 respondents fall into this category. The second is healthcare and education services that impact income potential or hard costs for individuals served. 16% fall into that category. The next is supportive services that also impact potential income or hard costs for individuals served, and that is 33%. And then the last truncation is supportive services that do not have an immediate impact on income or hard costs of individuals, and that is 25%. On the next slide, you'll see an additional segmentation of this portion of the data. In looking at, and by asking a question of the respondents, do you anticipate that this funding is at risk? Under housing, food, and utilities, 33% indicated yes, and 55% indicated maybe. Under healthcare and education, 58% indicated yes, and 19% indicated maybe. And then for supportive services that do impact income or potential hard costs, 30% indicated yes, and 51% indicated maybe. And then finally, under the supportive services that do not impact income potential or hard costs for individuals served, 50% indicated yes, and 23% indicated maybe to anticipated cuts. Additional information regarding the long-term impacts of these potential changes. When nonprofits were asked if they thought their funding was at risk and why, 41% responded yes due to federal funding freeze, 39% responded yes due to the congressional spending cuts, and 20% anticipated no impact. Nevada, again, is already ranked low in acquiring federal funding, and putting strain on providers from seeking additional further funding is at risk with the questions that are coming up. I want to be sensitive to the time. The next slide has some various quotes from some of the respondents. You can look at those at your leisure. I want to go to the final slide, and that is how the nonprofit sector is responding. As we have heard from many today, there's no way to predict or quantify the impact. But what I do want to say is that I can see already that the nonprofit sector is strengthened as we come together. We are committed to make sure that we are looking at data-driven solutions so that we can work together to build a process in collaboration with the state to understand program by program impact. We are also committed to continuing to have conversations around how to develop frameworks and agreements to sustain the most essential services. We will continue to convene and collaborate, coordinating with the nonprofit sector, including Nevada Grant Lab and Legal Aid Centers of Southern Nevada and state agencies. This includes the Governor's Office of Federal Assistance to share tools, best practices, and protocols to prepare for and weather an ever-changing federal landscape. Resources and information sharing, including guidance on how to respond to federal funding, certification in a timely manner, and encouraging a review of programs and projections of potential impact. We also want to share that United Way of Southern Nevada, in conjunction with Nevada Grant Lab, has proactively presented plans to present bills in this session regarding advanced payment and prompt payment of grants. And this is, again, a proactive solution to help the already strained nonprofits in managing this work. This particular change just compounds that and exasperates that situation. Again, thank you so much, Chair, for allowing us to join you, and I'm happy to answer any questions that you may have.
Thank you for your presentation. Members, are there any questions? Yes, Assemblymember Nguyen has a question.
Thank you, Madam Chair, and thank you, Mr. Rudd, for this very detailed report. I think this is a very harsh picture of looking at just the domino effect that this has just created for the nonprofit sector. On one of your slides on the potential long-term impact, you said 54% of nonprofits report the freeze could negatively impact full-time employee staffing. Did you have additional data on what that numbers will look like? I know that you're still collecting data, but in terms of the workforce, you said 46,000 Nevadans are employees of these nonprofits. So with this federal grant formula, 90% of the time you have to upfront the dollars and then get reimbursed. Do you know that potential of the staffing cut in terms of either a number to that 46,000 that could be affected by this?
Thank you, Sam Rudd, for the record. At this time, we do not have that data. We are working to continue to gather the data and would like to continue to be able to provide that supporting information to you all as we work together to respond to this issue.
Perfect. We would love to see that. Thanks so much. Thanks, Chair.
Thank you. Members, any other questions? No, I do have a follow-up, Mr. Rudd. First, I want to say thank you for the presentation. I did know that the nonprofits provided key services, much of which were funded through federal government grants or other mechanisms that are pass-through dollars. What I did not realize, though, was the number of agencies through which those grants are coming from. So I want to call that out maybe for our members and for the record. When we started this hearing, we started concerned about the Committee on Energy and Commerce and potential $880 billion in federal cuts, as was noted in the continuing House resolution last night that was passed. But this would identify that potentially cuts to the Committee on Agriculture, which is another $230 billion, could have effects on the nonprofit sector or the service delivery for some of our healthcare that we're providing through that sector. Or the Committee on Education and Workforce, which was another $330 billion, right? I want to make sure that folks are aware that maybe we're talking about more than just a single entity as part of our healthcare systems, and that potentially as we work to investigate what the solutions are, that we are broad in our perspective. Mr. Rudd, I'm wondering if you would be so kind as to follow up with the nonprofits that have responded and then send us a list of the core missions, right? What is it that they're doing? Is it food security? Is it legal assistance? Is it workforce development, so that we can get a clearer picture of the divisions that we should be looking at as we're preparing for healthcare and moving forward?
Thank you, Chair. And Sam Rudd, for the record, yes, we'll be happy to follow up on that.
Thank you. Members, any other questions? Okay, with that, I'm going to say thank you so much for being with us this evening. Thank you for staying late. Our presentations are now officially concluded, and that moves us to the last order of business this evening, where we will open for public comment. So thank you for being with us if you are still here. Members of the public may provide testimony, so if you would like to do so, please call 888 if you're on the telephone line, 475-4499, and then when prompted, provide the meeting ID, which is 812-0088-2540. If you're here in Carson City, please come forward, take the table. If you're in Las Vegas and you would like to provide public comment, please come forward at this time. We'll begin here in Carson City. Please turn your microphone on, state and spell your name for the record, and you may begin.
Madam Chair, members, Kim Young, Kimyoung, easiest name of the day. For the record, I am the CEO of the Children's Cabinet. The Children's Cabinet is a statewide nonprofit organization, and I wanted to take a moment to address our significant concerns as an agency regarding federal funding uncertainties. The Children's Cabinet serves over 44,000 Nevadans each year. 95% of our funding comes from federal sources. That includes either direct sources or through state pass-through grants. These potential funding freezes or policy changes that reduce the removal of federal support have a direct and devastating impact on the children and families who rely on our services. This funding is not just numbers on a budget, it's the safety net for working parents, vulnerable youth, and families in crisis. Without stable federal funding, we're talking about a working mother who loses access to child care assistance, making it harder to keep her job. An at-promise youth who struggles in a traditional school setting, who misses out on workforce development programs, helping them build a future. A parent working through the child welfare system to reunify their children who may not receive the critical support they need to keep their family intact. Or a survivor of domestic violence who may no longer have access to mental health services that help them heal and move forward. These aren't hypotheticals, these are real families, real challenges, and real lives that depend on our ability to provide consistent and reliable support. We must continue advocating for stable and sustainable funding to protect the programs that make a difference every day in the lives of Nevada's children and families. I appreciate your commitment to this work and your support as we navigate these challenging times together. Thank you.
Chair, members of the committee, Jonathan Norman, Jonathan, NORMAN with the Nevada Coalition of Legal Service Providers. I really just want to thank you for having this. I think it shows the seriousness of the potential of these federal cuts and is a great call to action that everybody needs to be doing everything they can to as Assemblymember Gray says, make sure in the reconciliation process that the millions of Americans and thousands, hundreds of thousands of Nevadans who are on the edge of poverty don't get swamped. I appreciate all the presenters tonight, the hospitals who are there to keep people afloat and provide that necessary care. I found the presentations, especially from the rural hospital associations, very grim, and I think this is a call to action for everyone in our state, so thank you.
Madam Chair, Chair Doniate, Dan Musgrove with Strategies 360, today representing U.S. Anesthesia Partners. I want to take a little different perspective on this in terms of the impact. And I can assure you, I know that this is not a money committee, and I'm not asking you or Administrator Weeks for a rate increase for anesthesia, but let me give you an indication of where we are right today, and then think about all the presentations that you've had already today, and then think about the ramifications on anesthesia here in the state. Now, U.S. Anesthesia Partners is the largest provider in the state. We serve 25% of the Medicaid population in the state. And we are inexorably linked with hospitals. So all the great slides that Mr. Kelly provided, think about our involvement in hospitals and those surgeries, and think about some of these statistics. Right now, in terms of number of anesthesiologists per capita, Nevada is, believe it or not, shocking, number 49 out of 51. We are in a position that our rates were actually cut in 2010, and we're operating at about 1991 rates for Medicaid. And consider these facts, that ever since Medicaid expansion went into effect, our costs have gone up 55 to 65%. The cost of labor just this year alone, we anticipate going up 35%. And so we are seeing a mass exodus in this country overall of anesthesiologists in the practice. So what impact does that have on Nevada? Where does it put us? Any lower than 49? And then think about what potentially happens at the federal level on those physicians willing to accept Medicaid patients. Thank you for the opportunity to speak.
Thank you. Good evening. My name is Robin Reedy, R-E-E-D-Y. I am here on behalf of NAMI Nevada. That's the National Alliance on Mental Illness in Nevada. Boy, has today been a day. I will tell you, we were just barely grasping at moving forward in this state when it came to behavioral health. Most of you do not know me. I worked for the Treasurer's Office for 17 years. I worked for the Department of Business and Industry for a year. I was chief of staff to a governor, the most conservative governor in the state, for about a year and a half. I had to deal with budgets. I had to be the one saying no to everyone. I learned that we were number 51, and I chose in my retirement for the last 16 years to be working with NAMI Nevada, and we were seeing some progress. Never enough, but some progress. This is what I've learned in my time in cutting budgets at the state. You will never catch up. You cut, and then we have some good times, some better economy, and we never bring it all the way back. In a family, when someone's trying to balance a budget, if year after year after year you can't, and you've cut and you've cut, you start looking for a part-time job. You start looking for other revenues. I don't know where those revenues are, and I know you are not a money committee. But my first glance would be assessing a fee on pharmacy benefit managers, because they're the only ones that are making money whether the economy goes up or down. And we need to do something to stop the cuts. Thank you. Thank you, Ms. Reedy. Thank you.
Thank you, Madam Chair, members of the committee. My name is Helen Foley, and I'm chairman of the board of First Med, which is a federally qualified health center in southern Nevada. In fact, we're the only gold certified FQHC in the state, which means we are in the top 10% nationally. We serve about 8,500 patients, so we had that many in 2024. 85% of those encounters have been through Medicaid. So cuts to Medicaid is very important and concerning to us. Every FQHC does primary care and then they select another discipline. Our other discipline is mental health, and we proudly have 56% of our encounters is for mental and behavioral health, with 31 being medical and then 13% psychiatry. Last year, we were awarded the contract by Clark County to take care of the children at Child Haven. And Child Haven, for those of you from Northern Nevada, it's a shelter for children who could no longer remain with their families. And so we provide all of the mental and physical health for these children. In addition to that, we provide at least half of the services for the 3,400 other children in Southern Nevada who are in foster care. All of these children come under the fee-for-service for Medicaid. It's just essential that we maintain these benefits and that we do the very best job we can. And so we thank you so much for dramatizing the situation tonight.
Good evening. My name is Abby Bernhardt. I'm with NAMI, Nevada. My journey with bipolar disorder started at 3 years old. During my last few years of elementary, I struggled with suicide ideology, and I thought about ending my life quite frequently. My mom tried to get me the resources and help I needed. It was a race against time. She tried to be proactive instead of reactive, but even with the state on her side, I had wraparound services, I had state therapist, and I had other supportive resources. My mom tried everything to support me. She tried to get me hospitalized. She tried to get me help. When I was 10 years old, I finally succeeded and tried to end my life. And it was an awful experience. It was the worst day of my life. I was on 10 medications over the course of between 7 and maybe 10. And it was due to step therapy. And when medication didn't work, my psychiatrist added another, and eventually I was on over 10 medications. When I attempted suicide, I was hospitalized for the 13th time that year. There's not enough hospitals in Nevada. There's not enough resources for mental health. And I've heard we're being sued by the Department of Justice. Please stick up and support my people. I fear for my people in Nevada, both fellow mental health advocates, the mentally ill, and anybody experiencing a health crisis of any concern. Thank you.
Hi, I'm Erica Fredenberg. I'm actually Abby's mother, who you just heard her case. And I just kind of want to add to her story. So my situation was when Abby's medication, sometimes the bottom falls out of it. And there are other things that happen. You lose a job, you lose the insurance, and those kinds of things, which actually happened to me because the business that I worked for was acquired. Left me in a situation where I was totally either going to have to pay for her medications myself or rely on a Medicaid program. And the thing that I just want to mention here is those medications can tend to be very high. Abilify, for instance, that's $1,000. And nowadays, I'm sure it's probably maybe $1,500 or maybe $2,500. Depending on the dosage that you're on. I really feel that your mental health is your foundation. If you don't have that, then you don't have anything. It just deteriorates from there. And so I just feel that in our society today, where mental health is becoming an epidemic, that it's really important to make sure that we do have medication in place for people and the health care that they're going to need. Because I can't fathom what would happen a year from now or 2 years from now in the situation that we're caught in the United States, where mental health is declining, and especially in Nevada, where we are actually at the bottom of the list. I think we're like second to the bottom of the list for mental health. And I really think it's really imperative. This could be a red light to where things might be going at a later time. Thank you.
Thank you. Is there anyone else here in Carson City wishing to offer public comment? Not seeing anyone in Las Vegas wishing to offer public comment? I see no movement there. AVH, is there anyone on the phone lines wishing to offer public comment?
If you would like to provide public comment, please press *9 or raise hand in your Zoom window to take your place in the queue.
Good evening, Chair Brown-May and members of this joint committee. My name is Catherine Nielsen. I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities. I want to first thank you for having this forum. As you've heard, that any cuts to Medicaid funding would impact the vital programs that provide essential health care to thousands of individuals in Nevada, and this includes people with disabilities. Reducing funding would have devastating consequences for those who rely on it for critical medical services, home care, life-saving treatments, personal care attendants. And as a parent, this issue is deeply personal to me. My 11-year-old daughter has type 1 diabetes, and Medicaid is our lifeline. It ensures that she has access to insulin, medical supplies, and specialized care that she needs to stay healthy. Without it, managing her condition would be nearly impossible, putting her health and future at a serious risk. And mind you, I'm also a state employee, so I do have state health insurance that helps offset some of these costs, but still, it's without Medicaid, over $800 out of pocket each month. Medicaid is not just a safety net, it's a necessity, and cutting it would put immense strain on families like myself, as well as healthcare providers and local communities. Thank you for working hard at protecting access to affordable health care and ensuring that no one is left without the care that they need.
Good evening, Chair Brown-May. I want to thank each Senate and Assembly Health and Human Services Committee member for your considerable time this evening. My name is Courtney Morin, and I'm the Manager of Advocacy and Family Engagement at Opportunity Village. We're here today to express concern about the devastating impact proposed federal Medicaid reductions will have on the over 1,100 individuals with intellectual and developmental disabilities we serve. So many of these crucial services we provide, including job training, supported employment, rehabilitation, and residential support, work to empower those who are often overlooked to live meaningful and increasingly independent lives. Currently, we operate these vital programs at an annual cost of over $16,350,000, and we're already facing a staggering deficit exceeding $6 million. A reduction in federal Medicaid funding will exacerbate this crisis exponentially. Let me share a story with you about someone we serve. For over a decade, G has thrived as part of the Opportunity Village family, earning wages through supported employment and now living in our residential community, Betty's Village. Together with our behavioral and nursing services, G's health and safety are ensured, enabling him to engage in supported employment, which is particularly important given his elderly father's inability to provide adequate care. Here's the thing, reducing Medicaid funding isn't just about cutting costs. It's about cutting opportunity, cutting support, and cutting hope for our most vulnerable population. It will shift the burden of care onto families who are already stretched thin, increasing strain on our healthcare system and ultimately cost our community more in the long run. We can all agree these individuals deserve opportunities, not further hardship. We're grateful for your ongoing commitment to supporting Nevadans with disabilities. Thank you again so much for your time this evening.
Hi, my name is Rebecca. I am both a BCBA, owner of an ABA clinic, and a mother of a special needs child that used to receive ABA services. Many of the speakers have already brought up that we are nearly last in the nation on behavioral health services. I know one option discussed was to reduce the reimbursement rate for providers. I can tell you that as a Nevada Medicaid reimbursement provider, it hasn't been evaluated since July of 2023, and we continue to remain under the national average as cost of living in our state continues to grow up nearly to the rate of California. As a provider, if this were to happen, I would be forced to stagnate the wage of my 40 employees at both of my locations. I believe a goal mentioned earlier in this meeting was to move people into a livable wage and out of poverty, and this seems very counterintuitive to that goal. The other alternative would be to pull out as a Medicaid provider, leaving the 25 children that I serve at my practice with Medicaid coverage without a service provider. The other suggestions brought up tonight were to reduce services or reduce eligibility for members. I have one client, we'll call him B. B would headbang his face through a wall when we first began services. Without my services, B likely would need repeated medical care. His father always came in almost on the verge of tears because he had no one to help him. Now B no longer does that behavior, and he is now safer. Another one of my clients, D, would throw desks at staff and scratch our faces and eyes. Without our services, D likely would have been moved into an inpatient facility and probably never come out. Finally, K. She is my teenage girl that I've had for about 8 years.
If you will
She
begin to
used
wrap your
require
comments, you're
4 or 5
over 2 minutes at this point. If you wouldn't mind beginning to wrap.
Absolutely. She would require 4 or 5 people to hold her down for medical care, simple medical exams. She no longer requires that. If these funds are cut, I want to know what I'm supposed to tell all of these kids, all of these parents. I don't know what to tell them if they no longer have help. Thank you.
Thank you for your comments. AVH, is there anyone else on the line for public comment?
If you have recently joined and would like to provide public comment, please press *9 or raise hand in your Zoom window to take your place in the queue.
Hi, my name is Evan Miller. I am a small business owner running a behavioral health outpatient clinic called Presence Therapy in Reno. I have to say I'm really impressed with the commentary and the support for Medicaid from all ends, both from our legislators and from our systems. Thank you, because I've seen a lot of stuff online that was really chaotic, and so this is really encouraging. So I would reemphasize that these services are essential. I have an option to choose whether to enroll in Medicaid, and we make a choice to dedicate our services to Medicaid people because we help teens graduate, we help adults become better parents, and we also help adults gain employment and climb the ladder. So we see Medicaid as the ticket to entry so that we can actually make a difference in people's lives as therapists. The new piece that I could add is it is very complicated to actually become enrolled with Medicaid as a provider. we had to hire an outside service to do this. So I can assure you, I'm not trying to fraudulently like take money that isn't deserved. But if it becomes more difficult to access this as a payer source, we'll have to make a difficult decision to just drop it. For example, HPN is a provider of Medicaid that is too complicated for our business. We're therapists. We're not grant writers. We're not legislators. So I guess I would offer that consider what you do to small business owners who are trying to use their licensure to help the community for a good purpose. Thank you for your time.
Follow with the last 3 digits, 822. You are unmuted and may begin.
Hi, my name is Robin, and I am the mother of a 5-year-old nonverbal autistic child who has benefited a lot from ABA therapy and other therapies as well. Medicaid is just a secondary for me, but I literally, even with my insurance, I can't afford therapies for her without some sort of assistance. My copays are $35 each, and daily ABA on top of speech therapy, occupational therapy, I couldn't afford it. When I didn't have ABA, we were limited to one insurance weekly because that's what I could afford. And I am begging you all to make some sort of exemption for special needs children. My daughter was totally nonverbal at first, and through therapy, she has a device that she can request, which is actually getting words out of her. And my only goal is for her to be able to care for herself in some capacity, but without therapies, that is almost a for sure no, it won't happen. And I, along with millions of other parents, will suffer greatly, not just us, but our children. It will be a double-edged sword for us. So I'm just begging you, please have some consideration for these children who cannot live any type of life without these therapies. Like someone else said, they'll most likely all wind up having to go into inpatient homes. We want our children. We don't want to have to give them up because there's nothing we can do for them. But that will happen with so many parents if Medicaid is cut for them. So I am just begging that you all have some sort of consideration for children who fault and parents whose fault it is not, that their kids are born this way.
Thank you so much for your comments. If you wouldn't mind wrapping, you're over 2 minutes. Thank you.
That's it. I'm done.
Thank you. AVH, are there any other callers on the line wishing to offer public comment at this time?
Chair, the public line is open and working. There are no other callers choosing to provide public comment at this time.
Thank you so much. At this time, I'd like to say thank you to all of our presenters. Thank you for being here to discuss your specific concerns and the vulnerable populations that you serve, our patient care, patient population, people with disabilities, people with mental health concerns, right, and diagnoses, like all of the vulnerable populations, our children. We appreciate the Department of Health and Human Services, a division of Medicaid. We really want to say thank you for joining us this afternoon, now evening, right? So thank you for being here for this transition. To walk us through your analysis and some of the key questions that have an impact on the potential federal funding cuts to healthcare and other divisions. We'll continue to work to focus on the health and well-being of our patients, our providers, and the economics of healthcare in our state. We look forward to continuing to work through this evolving issue with you as partners. Members, I want to say thank you to each of you for your time and your attention and your care for Nevadans and for our healthcare system. With that, this meeting is adjourned.